تفضل دكتور نبيل.
Can start.
تفضل دكتور.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين. أهلا ومرحبا بكم في رحاب المستشفى السعودي الألماني في الرياض، حيث يتجدد لقاءنا بسيادتكم من خلال مؤتمرنا السنوي الطبي العالمي لطب الأطفال وحديثي الولادة في المستشفى السعودي الألماني بالرياض، والذي يشاركنا فيه كما هو المعتاد كل عام نخبة من الأساتذة واستشاريين طب الأطفال وحديثي الولادة بالمملكة العربية السعودية ومصر والولايات المتحدة. ونرجو الله أن يكون مؤتمرا ناجحا وأن يعود بالنفع على مرضانا، وأن نتشارك الخبرات مما يفيد شباب الأطباء ويعود بالنفع كما قلنا على المرضى. وأتقدم لكم جميعا بجزيل الشكر والعرفان بالنيابة عن إدارة مجموعة مستشفيات السعودي الألماني وفرع الرياض، وبالأصالة عن نفسي دكتور نبيل شحاتة، رئيس قسم الأطفال وحديثي الولادة بالمستشفى. الشكر جزيل الشكر لكل من ساهم معنا في هذا الويبينار أو المؤتمر السنوي بالجهد أو بالوقت أو بالخبرات، وندعو الله جميعا أن يكون في ميزان حسناتكم وأن يعود بالنفع على الجميع. شكرا جزيلا، والآن سوف نبدأ أول جلسات المؤتمر. Thank you so much. Dear speakers and attendees, on behalf of the Saudi German Hospital Group Management, allow me to welcome you all and thank you all for participation in our yearly symposium, international symposium, that will discuss the updates in neonatal and pediatric care. I hope that it will be a fruitful meeting, inshallah, and it will benefit all of our young colleagues and our patients. I wish you all good luck and thank you so much for your time. Thank you. أستاذ علاء، أنت كده فتحت الكل، نبدأ ولا لسه؟
ايوه يا دكتور، خلاص مفتوح الويبينار مفتوح.
طيب، يعني أول سيشن هنبدأ إمتى؟ أنا مش شايف ناس دخلت بس.
احنا خلاص فتحنا للكل، الحين عندنا
طيب،
الاتندنس عم
المفروض إن إحنا
تدخل.
الساعة 4 بحسب الجدول بتاعنا.
صحيح، نبدأ على 4 إن شاء الله.
إن شاء الله تبدأ الساعة 4. هندي بس some minutes كده for all to join, then we will start. We can start now.
اتفضل دكتور اتفضل.
Can start. Okay. السلام عليكم ورحمة الله وبركاته. Now we'll start our first session. Our first speaker will be Professor Dr. Ahmed Al-Balidi. Dr. Ahmed Al-Balidi is one of the stars of the pediatric medicine in Egypt and in the whole Middle East, maybe in the international also. Dr. Ahmed will give us an overview about the monkeypox. Thank you, Dr. Ahmed. Dr. Ahmed Al-Balidi is ex-head of department of pediatric and neonatology department, Cairo University, and he is a famous star of all symposiums in the Middle East. Thank you, Dr. Ahmed, and you can start sharing.
السلام عليكم. يا ترى
عليكم السلام ورحمة الله وبركاته. الصوت كويس جدا بس اعمل فول سكرين وشير يعني.
أنا عملت شير، مش عارف
يعني
عندكم ظهرت؟
واضح واضح. توكل على الله.
طب أهلا دكتور نبيل وأهلا بيكم جميعا، ويعني يسعدني أبقى موجود معاكم دايما إن شاء الله. ربنا يدينا الصحة وبالتوفيق إن شاء الله يا دكتور نبيل في مؤتمرك الناجح كل سنة. هو هيجي the question is about monkeypox and whether this is important or not. And I think when it comes to infectious diseases and when it comes to the kingdom of Saudi Arabia, definitely أي infection في حتة في العالم مهمة جدا. It's very important. Why? Because this is our destination. When we come for pilgrimage, for Umrah, we are always meeting with people from everywhere. So if you think that monkeypox is a problem of African countries or something, no, we all meet in Saudi Arabia. And that's why this is a burden on the physicians in Saudi Arabia, because at least in the domain of infectious diseases, they need to be up to date for everything that happens all over the world, which is a very difficult task, by the way. But this is some of the peculiarities of being in Saudi Arabia. So I made the talk about monkeypox, the frequently asked question. There are 11 questions. I hope we can finish them in time. The first thing is, what's monkeypox? And monkeypox is a zoonosis. It's a viral disease that transmitted from animals to humans. It's a double-stranded DNA, belongs to the orthopox virus genus. So it is not like a chickenpox virus, although the name looks similar. And why I put the Democratic Republic of Congo? Because the first human case in 1970 was discovered in Congo. The name monkeypox originates from the original discovery in 1958. The virus was discovered in monkeys in a Danish lab. So from here came the name monkeypox. We know that there are two distinct genetic clades of the monkeypox. One of them is called clade 1, the Congo Basin clade, and the West African clade is clade 2. And the clade 1 is known historically to be responsible for more severe disease and more transmissible disease. In 2022, the names were changed, as I said, to clade 1 and clade 2. And additionally, at that time, clade 2 were subdivided into two clades, again, clade 2A and clade 2B. And the one that caused the outbreak in 2022 was clade 2B. Why I put the map of the Cameroon? Because it was surprisingly the only country where both clades have been found. So everywhere you find one clade, but Cameroon had two clades. And in 2022 outbreaks, all cases confirmed by PCR have been from the West African clade 2. What is the natural host of monkeypox virus? In fact, many animals have been suggested and identified to be susceptible for the monkeypox virus. Let's see them. Some squirrels, some types of squirrels, rats, Gambian poached rats and or mice, and the non-human primates like monkeys and apes and lemurs. So these are known that they are susceptible to the virus and accordingly can spread. What are the major milestones of the current monkeypox outbreak? In fact, we need to go to the 2022 monkeypox outbreak first. In the 6th of May, the first case was detected in the UK from an individual coming from Nigeria. And then in 23rd of July, 2022, again, the WHO Director General declares an outbreak of public health emergency of international concern. In May 23, this declaration was lifted due to sustained decline in global cases. If we take the summary of this outbreak, 110 countries were involved, almost 78,000 cases, with 112 confirmed deaths from it. But what about 2024? The virus of the 2024 outbreak started, in fact, in the Democratic Republic of Congo as a clade 1B. Then in July 2024, more than 100 lab cases have been reported in 4 countries neighboring to the Democratic Republic of Congo. So remember the Congo and the 4 countries. Tanzania was not included, but the 4 countries were Uganda, Kenya, Burundi, and Rwanda, just beside the Republic of Congo. And this is the data of August 12, where almost we are reaching 100,000 cases with more than 200 mortalities and 116 countries or areas or territories. At that time, in August 2024, the WHO put the long-term risk assessment of monkeypox, which, by the way, the WHO changed the name from monkeypox to Mpox. So they said the Eastern Democratic Republic of Congo and neighboring countries, high risk. Areas of Democratic Republic of Congo where Mpox is endemic, high risk. Nigeria and countries of the West, Central, and East Africa where monkeypox is endemic, moderate risk. And all countries everywhere where outbreaks spread by sex with men and spread predominantly with sexual contact, it's a moderate risk. And in August 14, the WHO director again declared the public health emergency of international concern. That's in August 14. And he said his reasons, because it's spreading fast in the Eastern Democratic Republic of Congo. At the end of the month, the UNICEF started to issue tenderness for the pox vaccines crisis. But remember, after the COVID vaccines and what have been raised, whether true or false, people lost the trust. So we are not sure if we needed the vaccines, who is going to take it, because there is an issue of trust and reliability. What about most recent data of the WHO regarding the Mpox? And the most recent data have been published 3 days ago. There is nothing after that. So this is on 13 November, the key figures. If you can go to this website, you can know even by country or whatever, but I focused on Africa. And you can see these data are updated weekly from the 1st of January till the 10th of November. And it's published on the 13th of November. And you can see the colors, each color represents country. And you can see Democratic Republic of Congo is the disaster, the red ones, followed by Burundi, the blue ones, and then Uganda. And they mentioned that there is underreporting of cases. In fact, there is underreporting of cases in the recent weeks. So we believe that the number is much higher. This is the map of the outbreak status. The red parts are active outbreaks where there are cases reported in the last 6 weeks, 42 days. And the ones in yellow, control phase, cases reported in the past 90 days. And the green, like Egypt and Sudan, cases reported since 2020, but not in the last 90 days. White one, there is no pox reported. And that's, by the way, in Africa only. This map, you can see the number, the confirmed number of cases, and you can see the dark blue with more than 1,000 cases is, of course, Democratic Republic of Congo. So if you want to see the most recent data that have been published few days ago, till the 10th of November 2024, 19 countries reported more than 12,000 confirmed cases and more than 50 cases of death. And the major three countries were Congo, Burundi, and Uganda. But look about suspected cases, more than 50,000 suspected cases and lab tested cases, including more than 1,100 suspected and confirmed deaths. So there is increase in the data about the monkeypox, although the reporting is not that marvelous. How it spreads? The direct contact with the rash, with the body fluids from a person with monkeypox, or touching towels, you can catch it from a hotel room, or contact with respiratory secretions. But they were focusing because they found that the main spread is men who are having sex with men. But the WHO prohibited using this or mentioning this because they do not want to stigmatize any person who developed monkeypox as a guy who had sex with men. So in fact, the WHO said, we do not want to publicate this or to show it, although it's on the website, you can see it, any type of sexual contact can lead to this, in addition to the classic ways from the rash and the body fluids. The pregnant woman can spread the virus to the baby, and from infected animals, if somebody is having these groups of animals or eat meat, he can get infected with monkeypox. The period of infectivity, from the time symptoms starts until the rash has fully healed and fresh layer of skin has formed, because when you will see the clinical picture, you see the skin get damaged, and then a new layer of skin develops. Until then, there is infectivity. And again, scientists still searching about the role of respiratory secretions, and if somebody is asymptomatic, can he spread, and the role of sexual secretions, urine and feces. What's the incubation period? From 3 to 17 days. And as we all know, any incubation period, you are not contagious during the incubation period. The clinical manifestations, there is a prodroma of the classic constitutional symptoms: fever, headache, muscle aches, but swollen lymph node, chills, exhaustion, sometimes cough and nasal congestion, then followed or accompanied by the rash, and symptoms typically last 2 to 4 weeks. The rash, by the way, appears on the periphery, unlike chickenpox. So it appears on the periphery, on the face, on the hands, on the soles of the feet, on the palms, although it can come, of course, to anywhere, any place, including the groin, the genital area, and anal regions. The number of lesions, surprisingly, from 1 lesion to several thousand lesions. And the lesions begin macule, flat, then become any of these: vesicle, pustule, umbilicated pustule, then ulcer, crusting, and scabs. So it's a more or less in the direction of the rash of the chickenpox, although the distribution is different, and umbilicated pustules are more specific or more likely in monkeypox than the chickenpox. And this is, you can see the rash, as I said, peripheral, but also can be seen on the trunk. And this is peripheral rash on the face and on the feet and hands. And on the left side, you can see it on the face, and you can see clearly the umbilicated lesions. The key characteristics of monkeypox, that the lesions are well circumscribed, deep-seated, and often develop umbilication on the same limb or the same site of the body. They look similar. So, for example, if you have pustules on the face, you will have all the lesions pustule on the face. If you have vesicles on the legs, it's all vesicles on the legs. And Fever usually precedes rash, very common the lymphadenopathy, and as I mentioned, the rash is centrifugal, more on the palms and soles. And look to the major difference from chickenpox. We always say chickenpox rash is itchy, but the patient described this rash as painful, not itchy, except when the crust develops, it starts to be itchy. What are the complications? Most cases, in fact, go away within 4 weeks, but the complications are more common in pregnant women, in newborns and children. So in pedia, we have a problem in the pedia because it's usually severe disease, and in immunocompromised persons. And these are the complications: secondary skin infection, pneumonia, sepsis, encephalitis, confusion, and maybe keratitis and loss of vision. The case fatality, classically, historically, we used to say from 0 to 11%. In the recent years, the case fatality 3 to 6%. Can we diagnose monkeypox by lab? In fact, we should, but there are certain precautions. We take specimens from the lesions, whether swab or crust from a healing lesion. The CDC accepts either dry swab from the lesion material, or if you want a material, so there is special medium called VTM material. And of course, from the crust, you can send the lesions. You take it by a swab. Surprisingly, the cotton swab doesn't work. It should be synthetic swab, sterile like polyester or nylon or Dacron. You cannot use these cotton buds, and it's not necessary to de-root the lesions before swabbing. And swabs, other specimens should be placed in different containers. You need to take from many sites, usually 2 to 3 sites, different parts of the body, and then you will do the PCR. Does past exposure to chickenpox provide any protection, whether the disease or vaccination? And the answer is no, because the chickenpox virus is herpes virus, while the monkeypox virus is an orthopox virus, so they are different and there is no cross immunity between them. Then the prevention of monkeypox. Can we prevent monkeypox? The CDC puts, yes, protect yourself and others, vaccines, safer sex, men-to-men sex is highly prohibited for this type of disease. Measure for those who are living in residential groups where, for example, butyl mucinin, home disinfection, handling with pets at home. And when we go to the vaccines, we have 2 vaccines. You can see one of them is the Genius. I call them for simplicity the yellow and the red vaccines. Why? Because the yellow vaccine is always with the yellow cap. There are 3 brands, different brands, but always al-ghata asfar, yellow cap, while the other one with a red cap. So if you go to this yellow vaccine, the Genius, it's made of a live strain of certain vaccinia virus. It's highly attenuated, but non-replicating. And remember, non-replicating, that's very important, because the side effects would be less related to spreading the virus from the site of vaccination to other sites. If somebody scratches the site and put his hands in his eyes, he doesn't develop keratitis. This is a non-replicating. Then we have low risks. It's indicated for the prevention of smallpox, monkeypox. Unfortunately, not for kids, but for adults from 18 years and above who are at high risk. And it's the preferred vaccine, as I said, because it's non-replicating. It's given in 2 doses. It's available in single dose vials, nus santi. It's given by subcutaneous injection, preferably over the deltoid, not in the deltoid, over the deltoid, subcutaneous. It's not given intramuscular. And you can get immunity, full immunity 14 days after the second dose, اللي هي بتبقى 4 weeks after the first dose. This is the subcutaneous injection over the deltoid. The vaccine comes frozen, so you allow it to thaw and reach room temperature. In room temperature, you can keep it for 12 hours. You cannot refreeze it again. And remember, this is a single dose, and you give it subcutaneously. What about the red vaccine? That's not a good one. In fact, it's called vaccinia virus, a pox virus related to smallpox, but cause milder disease. It cannot cause smallpox, but it can cause vaccinia, and vaccinia sometimes is severe. The problem is that replicating virus. That's why there should be extra care for vaccination site. It's important to prevent the virus from spreading from the vaccination site to other parts of the body, particularly the eyes or the genitalia. And this vaccine is given in a single dose by scarification, not subcutaneous, not intramuscular. It's by scarification with a certain needle, and it takes 4 weeks after vaccination to get the maximum immunity. It is not recommended for severe immunodeficient and several conditions. So these are the difference between them. The yellow vaccine, 2 doses, 4 weeks apart. 1 dose, remember, one of them is non-replicating, so it's more safe than the other, and you get immunity after 2 weeks from the second dose of the yellow vaccine, after 4 weeks from the red vaccine. Remember, it has a different type of store. It comes, by the way, in big vials, not a single vial, and it's stored till the distribution in -25. Then when it comes to you, it can be stored in the fridge for 18 months and must be given within 6 to 8 hours if kept in room temperature. And then the unused reconstituted vaccine may be stored in a refrigerator for 1 month. I don't want to go into the details how to use it, because I'm not sure whether anybody is going to use this vaccine, but they always for the skin where you are going to give the vaccine, unless it's clear it is dirty. And you need to ensure that the package of the needle is intact. You remove the vaccine cap. You can see this needle in B. They put it in the vial, and you take a drop like C, and then you use to puncture. You make 15 jabs in the area over the deltoid, vigorous enough so that you can see blood. So if you see blood, this is not a problem. In fact, it works. And then you close the vaccine by the rubber stopper, and you cover the vaccine site, because we are worried of the spread of this virus. You expect to see this within few days of the reaction. In fact, if you didn't see it in a week, you need to consult ourselves, because the vaccine may need to be repeated. Well, treatment of monkeypox is the last part. I put here the first, the guidelines for the treatment, who is going to be treated. Many people infected have a mild self-limited disease. So those where the prognosis is expected to be not so nice, like people with severe disease, people may be at high risk of disease, or people with aberrant monkeypox infection, for example, in the eye, in the anus, in the genitalia. Who at high risk of severe disease? As we mentioned, the pregnant woman, the breastfeeding, immunocompromised, pediatric population less than 8 years. Remember, I'm talking about here about the treatment and not the vaccination. And immunocompromised, anybody who has whatever the cause of the immunocompromised, if he has atopic dermatitis or active exfoliated skin conditions, or people with 1 or more complications. So there is no treatment approved specifically of monkeypox. However, the antiviruses that have been used for smallpox are taking approvals to be used against monkeypox, and we have 4 medications that may or may not be used: the tecovirimat, the vaccinia immunoglobulin IVIG, the cidofovir, and brincidofovir. And here I put the thank you one. Why? Because I think the time finished, and I have 4 or 5 slides to discuss about the treatment. But if the time finished, I think it's finished, because now it's 3:26. so we can stop
If you want to
here.
continue, we can, no problem. We can
يا
tolerate.
فندم
If you want to continue, we can tolerate.
لا اللي انت عايزه يا حبيبي
لا
هو
قول يا
لو
بيه
عايز.
لانها كمل لانه حاجه جديده.
طب يا حبيبي هو it will take 3 minutes 3
يلا
extra
ما فيش
minutes.
مشكله.
This is the first medication. It's called Ticovirimat. The Ticovirimat, by the way, is accepted in children. It's approved by FDA and EMA for smallpox in adults and children. Compassionate use to treat monkeypox, and you can see according to the body weight, even less than 6 kilograms, you can use 50 milligrams every 12 hours. There is capsules and there is injections, vials for IV, and the capsules can be mixed in liquid, whether breast milk or formula or applesauce or yogurt, so that you can give it by spoon. So it is doable. Should be taken within 30 minutes after full meal containing fat, so that it cannot be given on empty stomach. And the treatment usually is 14 days. However, it's allowed to be extended up to 90 days. It depends on the severity and the complications. But data beyond the 14 days are limited. What about the second one? It's the IVIG, Vaccinia Immune Globulins IV. It's licensed for the treatment of complications of Vaccinia vaccination. Remember, I mentioned the red vaccine. This red vaccine can have complication, particularly it's replicating. So this immunoglobulin have been designed for complications of the red vaccines. However, it's also used for the treatment of orthopox viruses, including the monkeypox during the outbreaks. However, we do not have effectiveness data about it and can be considered following exposure to monkeypox for prophylactic use, particularly in immunodeficient. Now, number 3 is the Cidofovir. And the Cidofovir, in fact, it's an antiviral that have been approved only for CMV retinitis in a patient who have HIV, in a patient who have normal kidney function, because this drug is nephrotoxic. So it was not designed for the monkeypox. And there is no data about the monkeypox effectiveness. However, it's have been shown in vitro and in animal studies that it is effective. It's unknown whether with severe monkeypox will benefit or not. So the CDC made an expanded access protocol, allowed the use of Cidofovir for the treatment of monkeypox in an outbreak. But remember, it's nephrotoxic. That's why the fourth one, which is the Tempexa or Brincidofovir, approved in 2021 for the treatment of human smallpox and in adults and pediatrics, including neonates, and took approval for children for monkeypox as well, although it is designed for smallpox. And you can see you can give it. It's present as suspension and tablets, and you can give it even below the age of 10 kilograms, 6 milligrams per kilo once weekly for 2 doses. So day 1 and day 8, and the dose change according to the body weight. And this should be taken on an empty stomach. وأخيرا فالله خير حافظا وهو أرحم الراحمين. And thank you very much.
Thank you so much, Dr. Ahmed, for your wonderful presentation, and as usual, you are perfect. Thank you so much.
الله يحفظك. بالتوفيق
شرفتنا
يا
الأخوة.
دكتور نبيل.
الله
ربنا
يكرمك،
معاك.
شرفتنا. شكرا جزيلا.
الله يحفظك.
So our next speaker will be Dr. Yasser Gazzaz. Dr. Yasser Gazzaz is a consultant PICU in National Guard Hospital, Saudi Arabia. And he will speak to us about sepsis in the PICU, state-of-art management. أهلا دكتور ياسر، شرفتنا وشكرا على مشاركتك.
السلام
You
عليكم.
can share your screen and توكل على الله.
Assalamu alaikum. I shared my screen. Thank
Yes.
you all for inviting me to this conference. Thank you, Dr. Nabil, for organizing this annual and amazing conference. Prof. Ahmed, it was great listening to your presentation. I learned a lot, and I'm going to be talking today about sepsis and PICU. So I'm just going to cover what's the difference between infection, sepsis, septic shock, how common is it really that bad, how does it occur, and how we can identify it and manage it. So the initial sepsis definition comes from this consensus group, which is a group of PICU and ID physicians who sat together and came up with a set of definitions. So it's a consensus and agreement among them. And basically, they identified the sepsis as this inflammatory syndrome, which occurs with fever, tachycardia, tachypnea, and increased WBCs. So two of those are needed to be there to call that this patient has systemic inflammatory response syndrome. And then we need an infection to be there with those to call that this is sepsis. So infection with systemic inflammatory response is sepsis, and when there's multi-organ failure, severe sepsis, then septic shock when there's hemodynamic involvement. So this consensus group, and it started in early 2000, and among there has been many updates in the adult regarding this definition, but not in pediatrics. And in adult in 2016, they identified sepsis as a life-threatening organ dysfunction by a dysregulated host response. So in terms of there's any infections or any trigger in the body, what usually occurs that there's some interleukins, cytokines, tumor necrosis factors, so proteins in our body that's going to react to infection. And the aim of those is to fight the infection at site. So if I have pneumonia, basically I'm going to have increased TNF, interleukins, WBCs, interleukin 6 and 12 to fight the infection at this location, which is lungs in case of pneumonia. However, when the infection is severe and we don't know why, some patients, instead of having this inflammation localized to the lung, they're going to have multi-organ involvement. So the interleukins, tumor necrosis factor, instead of fighting the local site of infection, they can attack the whole body. So it's dysregulated. And on the other hand, usually what we have interleukin 10s, 4, 13, that actually calm down this inflammation. But in a sepsis, there is upregulation of the systemic inflammatory, and the compensatory anti-inflammatory actually is lower. So basically, it's going to involve many organs. And this systemic inflammatory does not only occur with sepsis, it occurs in terms of if there's burns, it occurs in trauma, tumor lysis syndrome, so it occurs in any other pathologies. But when there's infection, it's called systemic inflammatory response with it, so it's called sepsis. Last year, there was actually a new consensus, and this time they did it differently. So instead of looking into several criteria, they sat together, they had the consensus criteria, they actually had initially 4 categories and 8, and they compare them against each other. And instead of looking into fever, WBCs, or tachycardia and tachypnea, they looked at organ dysfunction. So instead of looking at inflammation, they looked at organ dysfunction to redefine sepsis. And what else they did differently after they agreed on some scores, they actually had databases. So they had databases of patients, and they looked into those patients, and they applied the scores, and they looked which one of those was sensitive and specific to define sepsis. And basically what they had, again, no inflammation, but they looked at end organs injury. So they had respiratory, they had cardiovascular, they had coagulation, neurological, and basically among those 4 systems, if the patient had 2 or more scores, it's called sepsis. If he had with that a cardiovascular score, this patient is called to be septic shock. So there's no more severe sepsis with multi-organ failure. It's either sepsis or septic shock. So we got rid of one, the severe sepsis, it's not there anymore. And we have end organ injury as our marker for sepsis or septic shock. And they rated this to outcomes, which is length of stay in the ICU and mortality. So the higher the score, this patient has septic and basically have higher chances of death. So why do we have really to differentiate between infection and sepsis or septic shock? Because really the mortality is different. So when you have immune dysregulation and go into septic shock or sepsis, the mortality is higher, the quality of life is worse, and the length of stay is different. And based on that, our treatment has to be different. So antibiotics has to be given faster. There's more resilient or more planned to give fluid management and inotropic support, and basically those patients will need critical care management. How common is it? So basically, sepsis is the most common cause of death in children, according to WHO. So around 1.2 million children will die every year for sepsis. And another study looked actually into this. So the Sprout study, which is a sepsis prevalence, outcomes, and therapies, it actually looked into the prevalence of sepsis in ICU. So at any point, how many patients in the ICU out of total will have sepsis or septic shock? And they looked actually out across many continents. So between North America to Australia, Africa, Asia, and they had 128 ICUs among 26 countries. 7,000 children were screened. So out of those, 8% had sepsis. So if you collect all ICUs, basically around 1 out of 10 of the patients in ICU will have sepsis. The mortality in the ICU, so not even discharge mortality or 90 days, just patients who are in the ICU die 25%. So 1 out of 4 will die. And among the survivals, 17% will have moderate disability. And this actually varied. So the prevalence and the mortality varied among continents. So, and that depends on really on the background of the patients, on the critical care resources that's available in each continent. So if you look into the prevalence in the USA, it was around 7.7%, while in Africa, the prevalence was 25%. So again, the resources in Africa might be less than the US, so more patients will have sepsis. So basically, 1 out of 5 or 1 out of 4 in the African ICUs will be admitted with sepsis. When there are 2 studies that looked into this in Saudi Arabia, one of those that we conducted in National Guard in Riyadh, and another one was conducted in National Guard in Jeddah. The prevalence of sepsis was around 5 to 9%, so similar to kind of a North American prevalences. But what about the outcomes? So the outcome in terms of mortality, again, the African had the highest mortality in Asia, 40%. So 2 out of 5 patients who come to the ICU with sepsis will unfortunately die. 1 out of 3 in Australia will die. The numbers in North America and South America were less, so around 20% and 11%. When we compare this to studies in Saudi Arabia, so mortality in Saudi Arabia ranges again from around 20%, but from 17 to 25% among centers in Riyadh and Jeddah. So National Guard, our mortality was 17%. King Abdulaziz Medical City National Guards 24%, King Faisal Specialized Hospital 26%. And again, another study in King Faisal that after applying some improvement bundle was 18%. So we have a disease that's actually very prevalent in ICUs with a very high outcome. So how to fight sepsis? There has been many guidelines to do that. So initially comes from the American College of Critical Care Medicine and the Pediatric Advanced Life Support, where they had several guidelines starting 2002 and updated twice after that, 2007 and 14. And the Surviving Sepsis campaign come from Society of Critical Care Medicine and the European Society of Intensive Care Medicine in 2020. And basically, those are the 2 guidelines. Maybe the Surviving Sepsis one is the newest guideline. And basically, they divide them into 2 or 3 bundles, I'd say, which is how to recognize sepsis, how to manage sepsis, and in the American College one, they have the performance bundles, how to know how well or bad you are. So both of them basically recommend that we have to identify sepsis earlier. So the recognition bundle, or there has to be systemic screening for sepsis. So how we do systemic screenings? There's not a universally accepted one. There has been many tools, and that's customized to the hospital that the patient is or how they are doing it. So in the UK, they have the Sepsis Trust, which is like a huge bundle to manage this, and an organization meant to fight sepsis. So it starts with that the patient doesn't look well. So in any hospital, if the patient does not look well, they have to go and see, does this patient has infection? If yes, has infection, they look into their vitals. If there's tachycardia, bradycardia, they has fever, they has high risk factors like basically having a central line, or this just he had the surgery, recent discharge from ICU, and basically there is a scoring system that says, okay, most likely this patient has sepsis. This patient has to be managed as sepsis shock, and basically what they have a bundle they call the sepsis 6, which is basically oxygen, antibiotics, etc. In the USA, each center has done it differently, but they look into it other than the patient comes unwell. They look, the trigger here is different, not looking unwell, but a patient who has fever, basically. So patient comes with fever, they look into their vitals. There's tachycardia, does the patient has tachycardia, has hypotension, has perfusion, and according to those, they go into scoring And based on this score, most likely this patient will have sepsis, and they'll manage as well as a septic shock. Again, so this can be electronic, can be paper-wise. I think the best way or the easiest way to be done is to look into tachycardic patients. So you have a tachycardia, we go and have to assess the patient and see this tachycardia can be explained by pain, can be explained that the patient is receiving a lot of Ventolin, so side effect of our medication, or most likely this patient has sepsis. We have to manage. And when we have to manage, there has to be a protocol and guidelines for this. And the way we divide them are resuscitation and stabilization bundles. So there is a very clear pathway for, again, sepsis and septic shock. And it's a pathway. We start it step by step and see if the patient responds or not. The first thing is basically giving oxygen and securing an vascular access, whether IV or IO, depending on the patient's situation and if they're able to get. And then it's antibiotics and fluids. So really, does giving antibiotics early differ? So yes, this has been looked at in different studies. We've conducted this in actual National Guard Health Affair, and we found if antibiotics delayed beyond 3 hours, the mortality increased from almost 15% to 33%. And when we corrected for other risk factors, so how sick is the patient, there was actually odds ratio of 3.8% for mortality. So patients who you delayed antibiotic beyond 3 hours, their chance of dying almost quadrupled. So 4 times of the patients who received antibiotics before 3 hours. The same findings were found in CHOP, so from the US. Again, mortality beyond 3 hours increased from almost 6 to 8% to 21%, through 3 times the mortality increased by given 3 hours. And the guidelines, what we basically say, if you have an infection, which is the trigger, you need to give antibiotics. And that the antibiotics, when the patient is hemodynamically unstable, that required fluid or anatropes, you need to give antibiotics as soon as possible within 1 hour. If the patient, hemodynamically is kind of fine, but has multi-organ failure, they say you can wait for 3 hours to give antibiotics. And the reason is you have more time to assess the patient. So if they clearly in shock, there's no reason to wait. You have to give antibiotics. If it's not clear, the patient looks unwell, you can do more assessment. And that's basically usually is a blood gas to look at the base deficit, do lactate. If the lactate is high, base deficit is huge, give antibiotics as soon as possible. The other thing is to give fluid. So we know just by physiology, the more fluid you give, if the heart is healthy, it's going to contract better and give you better cardiac output, better blood pressure. And that if the heart is healthy. However, if you have the sepsis involves the heart, so the heart has heart failure, or there's it's actually myocarditis plus sepsis, you have to be really cautious. And how do we know that? We have to look into the liver size and listen to the lung for crepitation or rales. So if the liver is enlarged and there's crepitations before or after fluid bolus, and the patient actually deteriorates after fluid bolus, this is where we have to slow down on fluid, and the patient needs pressors basically. And what the guidelines says, so administer fluid resuscitation, aiming to reverse signs of shock, and be really careful with hepatomegaly and rales. And the difference between the two guidelines basically is you can give up to 60 ml per kilo, 20 ml per kilo for each bolus, and a patient that we don't think the heart is involved, or when we give fluid bolus, it doesn't affect the liver or the lungs. However, based on a study that was done in Africa for a different population, when they give boluses, those patients did worse. And the main reason was there's no resources. So we know if you give boluses, some of it might leak into the lungs, making the respiratory status even worse. So if you give a lot of fluid and you don't have a mechanical ventilator or non-invasive ventilation, those patients are going to do worse. So what they recommend is to be cautious with giving the volume. Don't give beyond 40 ml per kilo and give less boluses basically. So 10 ml per kilo per bolus. We gave the patient antibiotic, we gave fluid resuscitation in our situation up to 60 ml per kilo. This patient still does not do well. They recommend to start inotropes. So initially, historically, more than 10 years ago, dopamine was one of the classic drugs, and then there has been a change into epinephrine, but does really epinephrine make a difference? So one of the first studies that looked into that, it's a study from Brazil where they actually compared, it was a randomized controlled trial, double-blinded. They compared epinephrine versus dopamine at different doses, and they had around 120 children. There was a difference, as you see, in the Kaplan-Meier curve in mortality. So the more drops in the line, the more dots mean more patients died. So they had more patients who died on dopamine versus epinephrine. Another study was done after that, comes from India. They did it's the same thing, same study, and the resolution for shock was better in epinephrine, and the mortality rate was higher in dopamine. And based on those studies and other, both guidelines actually recommend epinephrine over dopamine, and even they drop dopamine out completely outside. So if you have a patient with a septic shock, you can start epinephrine. If you think if the patient with epinephrine still does not improve, they recommend the second line to start norepi rather than dopamine. Usually when they don't respond, we start thinking about steroids, and steroid historically has been used because of when they looked into autopsies for patients they died, they found that their adrenals had basically thrombosis. So they thought maybe they need steroids and the patient respond to steroids. So there are some clear indications for hydrocortisone, a patient who's known already to have adrenal insufficiency, so congenital adrenal insufficiency, patients with purpura fulminans, or actually patients who has been steroid for a long time, so more than 2 weeks of steroids, they're going to be adrenal suppressed. So those patients for sure are going to give steroids. What about patients who are on epi and norepi and they don't respond to you? Should we give them hydrocortisone or not? Previous articles and this meta-analysis shows there's no difference. So if we give hydrocortisone or if it did not, we don't have a clear answer, saying that those are not randomized controlled trials. Those are only retrospective. And if you can look into the dates, there are studies from the mostly, or all of them, from 1975 to 1996, only one study in 2009. And basically what the guideline says, if you have a hemodynamically stable patient, please do not give hydrocortisone, but they are unstable, they cannot say, they did not suggest to give or not. They say it's up to you. If you want to use it or if you don't want to use it, it's purely up to you. What I can say, there's currently a study undergoing. So the study comes from US and Canada. They did a feasibility trial and the big trial is going. It's called the SHIPS trial, the Stress Hydrocortisone Pediatric Septic Shock Trial. That's actually conducted among many centers in Canada, USA, Brazil, and Saudi Arabia. And they basically comparing hydrozone versus not, and the sample size reach 50%. Hopefully in a year or two, we're going to have an answer. This is the study that we are doing in here in Saudi Arabia as well, among the study. So I would like to summarize, sepsis is not infection, it's infection plus immune dysregulation. We don't know why some patients will have this, why others we don't know. Maybe in the future we're gonna have some answers. Sepsis kills, as you can see, 1 out of 5 children. So mortality is up to 20% in Saudi Arabia and even the USA. The treatment is early recognition. So whatever tool you're gonna use, paper or a nursing tool or electronic tool, it has to be implemented. Early recognition. Antibiotics has to be given as soon as possible as you think this patient has sepsis. Fluid resuscitation is a key. And at the end, if you can't measure how well you are, so looking into mortality, look how fast you're giving antibiotic and fluids. If you don't know those, you really need to know those, because if you cannot measure them, you cannot know if you're doing well or bad, and then you cannot improve. And with that, I end my presentation. Thank you.
Thank you so much, Dr. Yasser, for your wonderful presentation. It's really amazing. And thank you for sharing us your experience and all the time that you will be with us, inshallah. Thank you so much.
Thank you. That took a moment.
So stop sharing, huh? So our next presentation will be by me. I will speak, inshallah, shortly about bronchopulmonary dysplasia, just for prevention today, and we will have another lecture from my clinic professor tomorrow, inshallah, in the same subject. So I will start bronchopulmonary dysplasia prevention. Bronchopulmonary dysplasia is also known as neonatal chronic lung disease. It is a major cause of respiratory illness in preterm infants. It is an important contributing factor in increased risk of mortality and morbidity in the preterm population. Terminology: prematurity. Different degrees of prematurity are defined by gestational age, which is calculated from the first day of the last menstrual period till less than 37 weeks gestational age. or can be also considered by birth weight. Bronchopulmonary dysplasia is a chronic lung disease characterized by disruption of pulmonary development and/or lung injury in the context of preterm birth. Clinically, bronchopulmonary dysplasia is defined as an ongoing and on respiratory support is postnatal age or 36 weeks post-gestational age. I will speak about our approach. General measures are provided to all infants who are at risk for bronchopulmonary dysplasia, extremely preterm infants, gestational age less than 28 weeks. We have to give antenatal steroids. Antenatal growth steroids are appropriate for pregnant women at 23 to 34. And there was a debate here for adding steroids starting from 23 or 24 because many of the gynecologists are refusing to add it, claiming that there is no alveoli to be recruited, but it will improve. It's better to start even with 23 weeks gestation if they are at high risk of preterm delivery within the next 7 days. Nutrition. And our central nutritional goals are set to provide adequate caloric intake to promote somatic and lung growth. Mother's breast milk is the preferred nutritional source from the first day, even if baby cannot take or tolerate, just put on the buccal mucosa, and even you can just also add to the skin of the baby from outside. Mother's milk has a good benefit. Vitamin A, some centers routine vitamin A is available in ventilated weight if the birth weight is less than 1 kg.
دكتور نبيل الصوت لو سمحت.
صوت مش واضح ولا ايه؟
قرب شوية لو سمحت.
يعني
تمام.
كده كويس؟
تمام دكتور، تمام، تسلم.
سامعين كله تمام؟
تمام دكتور، تمام.
طيب اوكي. Fluid management after the first week of life, fluid intake is generally restricted to 130 to 140 ml per kg per day to maintain natural or slightly negative fluid balance. يعني zero balance or slight negative will be the best. Caffeine, we administer caffeine to all extreme preterm infants within the first 24 hours of life. These units have a highest risk of BPD. Respiratory support. The goal of the respiratory support for infant at risk for bronchopulmonary dysplasia is to maintain adequate oxygenation and ventilation while minimizing respiratory intervention that may lead to lung injury. In infants who require supplemental oxygen, we set the peripheral oxygen saturation SpO2 target range between 90 to 95%. In most preterm infants, we use early positive airway pressure support, typically with continuous positive airway pressure or CPAP. In preterm infants who require intubation soon after birth, we provide early surfactant therapy. In preterm infants with respiratory failure, we use a mechanical ventilation strategy that aims to minimize ventilator-induced lung injury. In infants with severe persistent respiratory failure, despite optimal setting in conventional ventilation, a trial of high-frequency ventilation is used to minimize the lung injury. Postnatal steroids. We don't routinely administer postnatal systemic or inhaled glucocorticoids to prevent BPD. Systemic glucocorticoids has reserved for extreme preterm infants who remain ventilator dependent and or require oxygen supplementation more than 50% at 2 to 4 weeks of postnatal age. Interventions. Measures that are routinely used. The following interventions are generally used in combination to improve the outcome, including reduction in the risk of the bronchopulmonary dysplasia in at-risk preterm infants, especially extremely preterm infants, gestational age less than 28. Antenatal steroid therapy, protective ventilatory strategies that minimize paratrauma or volutrauma in infants who require respiratory support for neonatal respiratory distress, mother's breast milk, caffeine, modest fluid restriction. Measures that are used selectively, preterm infants who remain ventilator dependent at 1 week after birth are at risk for developing bronchopulmonary dysplasia. Such neonates may benefit from additional preventive measures, including selective use of postnatal steroids therapy in high-risk extreme preterm infants. Some centers are using vitamin A supplementation, if available, alone in extremely low preterm babies, infants who require mechanical ventilation support, and selective use of trial of diuretic therapy. Measures that are not used. Routine use of postnatal steroids therapy in all at-risk infants. This is because of outcome adverse effect, especially when in the past was using dexamethasone. The outcome for the neurological outcome was very bad, so they stopped it. And now, if you will use, we are using a course of minimal doses of hydrocortisone. Routine use of inhaled nitric oxide. Nitric oxide will not benefit in preventing the bronchopulmonary dysplasia, since the dose not appear to be effective. Late surfactant administration is not effective in preventing also bronchopulmonary dysplasia, since this does not appear to be effective. Use of bronchodilator, some are giving bronchodilators like Ventolin or steroids, but they are not benefit for this, since limited evidence and did not show efficacy when used. Right, we'll go to the interventions a little bit in details. Steroids, as we told, antenatal and postnatal. Antenatal steroid therapy is an effective intervention for prevention of respiratory distress syndrome, resulting in less need of mechanical ventilation and oxygen supplementation, risk factor for bronchopulmonary dysplasia. Antenatal steroids are appropriate for gestation individuals from 23 to 34 weeks of gestations who are at risk for preterm delivery within the next 7 days. The doses, they are different for many centers. Some are giving it divided on 4 doses, 60 mg, dexamethasone. The best is betamethasone. And some are giving it in 2 divided doses, 12 mg. And recently, they are speaking about single dose 24 mg. Postnatal steroids, we don't routinely administer postnatal steroids to prevent systemic, but systemic steroids are reserved for extreme preterm infants who remain ventilator dependent and require more than 50% oxygen, and it may facilitate the extubation of these babies. And as we told, we are giving very minimal doses of hydrocortisone course. Surfactant, exclusion surfactant therapy given within the first 30 to 60 minutes after birth is effective in prevention and treatment of the RDS and reduce the need of ventilation and oxygen supplementation.
دكتور نبيل الصوت لو سمحت معلش.
نعم. الصوت ايه؟ الصوت مش واضح؟
الحين واضح الحين واضح.
طب هو في مشكلة فين؟ أنا ما غيرتش ولا شيء. في مشكلة في النت ولا فين؟
تفضل دكتور، أنا بس لازم أقول لحضرتك إذا الصوت موعد واضح هخبر حضرتك.
طيب أوكي ماشي. So the surfactant, early use of surfactant is the best to prevent bronchopulmonary dysplasia, as it will minimize the need of these babies to oxygen and to ventilation. Fluid management is also a good option. The goal of fluid management is to maintain neutral or slightly negative fluid balance. Babies who are in the first days have positive balance every day will have a problem or will have a high risk for bronchopulmonary dysplasia. So it's better to keep such babies on the zero balance or minimal negative, not too much negative, but positive balance is not wanted at all. Our usual practice is to restrict the total fluid intake to 130 to 140 milli per kg per day after the first week of life. However, the fluid status of the patient must be monitored frequently. If the patient, for example, have polyuria or have diuresis, so here I can increase and I can try to replace the excess urine. What's more than 5 ml per kilo per day can be replaced. Caloric intake also should be taken in consideration. So if you want to minimize or restrict the fluid, you can give more calories. If the baby is on OGT feeding or something, we can add MST oil to increase the caloric intake of these patients to help them to recover. Ventilation strategies to minimize the lung injury. Most of the most obvious cause of bronchopulmonary dysplasia is the lung injury from the ventilator, especially if it is for long time. Mechanical ventilation is crucial for preterm infants with respiratory distress syndrome. Mechanical ventilation leads to tissue injury and inflammation, contributing to bronchopulmonary dysplasia. Strategy focus on reducing lung injury while ensuring proper oxygenation and ventilation. Lung protective strategy, especially with the high frequency mode. Ventilation strategies to minimize lung injury. These strategies include avoidance of mechanical ventilation through peripheral use of the non-invasive CPAP, for example, or a high flow nasal cannula. The use of, if I have to use ventilation, I have to use a protective mode, which is volume target ventilation, اللي هو with volume guarantee. Using low tidal volume from 4 to 6 ml per kg, or the use of high frequency oscillatory or high jet as a rescue therapy. So high frequency will be good, but we have to be sure that the baby did not have thrombocytopenia before starting high frequency ventilation, and it should be the low MAB strategy. What are the strategies to minimize lung injury? As we told, most of them will take in consideration that the tidal volume will be low, the PEEP will be about 5 per kg, and the expiratory time also should be minimized. And if it is possible to use CPAP mode or high flow or RAM cannula, high flow nasal cannula or RAM cannula. And the most suitable mode is the high frequency with low MAB or low MAB strategy ventilation to protect the lung. Caffeine for most extreme low pulse weight infants below 1,000 grams. We suggest prophylactic caffeine starting from the first day of life. The available clinical trial data suggests that intervention is safe and effective for reducing bronchopulmonary dysplasia and perhaps other long-term complications like ROB. So caffeine now, before we were using it before extubation and after some days, but now is recommended from the first day, and it will continue even to protect against ROB until the baby will reach 32 or 33 weeks and above. and has no apnea, so we can wean caffeine. When we wean the caffeine, we'll wean caffeine slowly over 3 days, and we should keep the preterm observed and monitored for 3 days after weaning for a relapsing apnea of prematurity that can happen. Vitamin A. Extreme preterm infants may have vitamin A deficiency, which may promote for development of the bronchopulmonary dysplasia. However, data are conflicting as to whether vitamin A supplementation reduce the incidence of bronchopulmonary dysplasia. If there is a benefit, it appears to be modest. Vitamin A is given it is administered within 24 hours after birth and an intramuscular injection of 5,000 international units. This dose is then provided 3 times per week for 4 weeks. Enteral water-soluble vitamin A is not used for the purpose because although it may increase the plasma retinol level in extreme preterm infants, it does not appear to reduce the severity of bronchopulmonary dysplasia. So, vitamin A for bronchopulmonary dysplasia should be injection and not oral. Evidence supporting IM vitamin A supplementation includes the following. Meta-analysis of 5 trials showed IM vitamin A slightly reduced the bronchopulmonary dysplasia rate, but not significantly. A retrospective study from USA in 2010 found that vitamin A shortage did not impact mortality or bronchopulmonary dysplasia rates in the NICU, with supplementation dropping from 27% to 2%. A post subgroup analysis suggests vitamin A may benefit lower risk preterm infant. Source study data was from 99, 30 years now, so it's not so strong evidence. Test milk, this is one of our items that we are stressing on, and we are trying all the time to encourage our mothers to give us the breast milk, especially the first one from colostrum. And even if the baby is not tolerating, try to use it. As we told before, sometimes we are just putting it in the buccal mucosa of the baby or on his skin from outside. Mother's own milk is preferred from the nutrition of preterm infants, as it offers several advantages over formula, including prevention of bronchopulmonary dysplasia. There was a meta-analysis of 17 cohort studies and 5 retrospective done on 8,661 units, demonstrated that human milk compared to formula is associated with a lower incidence of bronchopulmonary dysplasia. Although the certainty of this finding is low, in addition, an observational study found that breast milk from the mother reduced the risk of bronchopulmonary dysplasia and reported a dose-response relationship with an increased reduction in bronchopulmonary dysplasia as the volume of the breast milk is increased. However, the results of this study are limited by the potential of confounding factors. So, for all, breast milk is the best to prevent many things, not only bronchopulmonary dysplasia, but it is one of the preventive measures for bronchopulmonary dysplasia. Unproven interventions that are ineffective in preventing bronchopulmonary dysplasia include sustained inflation. There was strategies we tried before to see if they will affect the bronchopulmonary dysplasia, trying to recruit more the lung more by sustained inflation. Sustained inflation in the delivery room for infants requiring respiratory support, inhaled nitric oxide alone or in combination with surfactant, bronchodilators, and supplementations. And all of this did not help to reduce the bronchopulmonary dysplasia. Sustained inflation, we were doing it even by the TPC catheter. We just put your finger as if you are giving a breath and sustain for some seconds, then remove. This will help to inflate the lung or recruit the lung more than usual, but it was not proved to have an effect on reducing the bronchopulmonary dysplasia incidence and rate. And the side effect of this, or the harmful that the baby can develop if the one doing this is not expert, the baby can have pneumothorax. Inhaled nitric oxide, the available data is not supporting the use of nitric oxide either alone or a combination with surfactant as an intervention to prevent bronchopulmonary dysplasia. We agree that the guidance of expert panel provided by the National Institute of Health in 2014, American Academy of Pediatrics clinical report that recommended against the use of nitric oxide in routine management in preterm infants below 34 weeks gestation who require respiratory support. Late surfactant, as we told, late surfactant can help. What about late surfactant? Late deficiency of postnatal surfactant production or surfactant dysfunction has been proposed as a contributor of the pathogenesis in bronchopulmonary dysplasia because it may be associated with episodes of respiratory deterioration in ventilator-dependent preterm infants. However, late administration of surfactant does not appear to reduce the risk of the bronchopulmonary dysplasia. Combination of steroid and surfactant, data on use of the combination of surfactant use are limited. Thus, therapy cannot be recommended until there are more definitive data or established. Maybe in the future, more studies can be done and they will say that it is effective. Bronchodilators, the data on the use of bronchodilators are limited. The systemic review only a randomized trial had usable outcome data. It was on 173 preterm infants, less than 31 weeks. Salbutamol did not reduce the risk. That's why salbutamol is not recommended. Some are using steroid, but as we told, it is not mandatory or will not help to prevent the bronchopulmonary dysplasia. Long chain fatty acids, DHA and omega 3. طبعا omega 3 is one of the key player now in everything. All women or babies are taking omega 3, but in DHA and omega 3 are crucial for brain and retinal development. Preterm infants miss fetal DHA question in the third trimester if the mother has deficient, and that's why they are recommending now most milk formulas with DHA. Polyunsaturated fatty acid supplementation aids neurocognitive and visual development, but doesn't prevent bronchopulmonary dysplasia. So they are in a benefit for the brain, but not for the bronchopulmonary dysplasia. Superoxide the same, this is an enzyme and it has the same. There is no benefit in reducing bronchopulmonary dysplasia. If there is any medication they can use, there is one medicine they are trying to add now, benzodiazepine. Is as an CN derivative, that anti-inflammatory prophylaxis, the use of nebulized, the use as nebulization as a preventive measure for bronchopulmonary dysplasia was studied in a single small pilot randomized trial. And a single study is not so good data to go behind, but this was the only study recorded. As such, additional data are needed before the use of this drug as a common use. We can recommend before we can recommend the routine use to prevent bronchopulmonary dysplasia. Studies investigating the use of bentofoxylene is in the treatment of the neonatal sepsis are in need for further discussion. In summary, preventing bronchopulmonary dysplasia in neonatal infants, prioritize in non-invasive support like CPAP and high flow nasal cannula will be better than conventional ventilation. And if you have to ventilate, so the high frequency mode will be better. Reserve endotracheal intubation and surfactant administration for those failing non-invasive support. Use volume target ventilation if you will use mechanical ventilation or even high frequency ventilation. Use caffeine and vitamin A from the first day for bronchopulmonary dysplasia. Consider dexamethasone in high risk cases after the first week, but as we told, dexamethasone when studies for the long term care, it was not good, and hydrocortisone is better. Hydrocortisone offers benefits, but potential adverse effect as all steroids. Newer experimental therapies promising in the prevention of the bronchopulmonary dysplasia in extremely preterm infants, and more studies are needed to be done. This will end my presentation, and tomorrow, inshallah, we will have the same topic. We'll have a lecture from our professor in Mayo Clinic from USA to share the new strategies for this issue. Thank you so much, and I hope it was okay. Our next speaker will be Dr. Ali Latifi. Dr. Ali Latifi is a consultant pediatric neurologist and epilepticist. He is the chairman of the clinical neurophysiology medical. Welcome, Dr. Sharing screen.
Assalamu alaikum. Do you see my slide?
Yes, we can see it.
Okay, so Bismillah ar-Rahman ar-Rahim. Thank you so much, Dr. Nabil, for the kind invitation, and thanks to Dr. Riyam Anizi too, and thanks for the host of this symposium and for sharing the link for live streaming for residents to attend freely, and this is really very generosity to share knowledge. And my topic is about the neonatal seizures and the update on treatment. So the outline will be we should be able to classify seizure according to the 2021 classification by the ILAE, and also knowing the common etiology of the neonatal seizure and epilepsy starting in the age of neonates, and also update on the treatment following the guidelines published by the International League Against Epilepsy in 2023, and also to emphasize the key role of the EEG in the neonatal unit, whether continuous conventional EEG or amplitude integrated EEG or the cerebral function monitoring CFM. And then maybe to discuss the prognosis of neonatal seizure onset and risk of future epilepsy. So the classification of the neonatal seizures will follow the ILAE, and in the patient with the critical illness or with the clinical suspicion of a seizure, this need to be confirmed by the video EEG or amplitude integrated EEG. And if there is no correlation with the ictal pattern in EEG, then the event is not seizures or non-ictal seizure. And if there is a seizure activity on the EEG, either there is a clinical association with this ictal activity on the EEG, or there will be no clinical signs. If there is no clinical sign, then it will be electrographic seizures only. And if it is with the clinical signs, then either motor or non-motor or sequential or unclassifiable seizure pattern. The commonest motor usually in those age group is the clonic probably, and then tonic and autonomic or automatism. And the non-motor is the automatism and behavioral arrest. And the sequential will be a combination of the symptoms and signs and moving from one changing to another within the same seizures and probably from side to side. This is also accompanied by changes in the EEG during this ictal pattern. The classification here on the right, you can see is that the electroclinical and the electrographic alone, and then from there you proceed to the epilepsy syndrome in the neonates. And this is also called the etiology classification, we will discuss soon. So the clinical description of the seizures in the neonate, as we mentioned in the previous classification, the common is clonic, and usually this is a jerking, either symmetric or asymmetric, can be focal, and which is more reliable in diagnosing clinical seizure if it is unilateral or even bilaterally. Typical seizure types in the neonatal stroke and also in the cerebral hemorrhage, or may be seen in the hypoxic ischemic encephalopathy. The second probably is important also as a clinical finding is the asymmetric tonic or sustained increase in the muscle lasting usually for a few seconds. And if it is focal, unilateral, or bilateral. If it is generalized, then probably it can be non-epileptic also. Typically appear in the developmental epileptic encephalopathy. The sequential seizure, this is important in neonatal units and also to be recognized by the neonatologist or neurologist. As well as the term is the event with the sequence of signs and symptoms and EEG changes at a different time. And usually this need EEG to identify them, and this is commonly seen in the early epileptic encephalopathy with channelopathy, and for example, the KCQ2 or SCN2A. So this is depict the degree of the certainty in identifying the seizure in neonate. So baby with the risk, high risk for seizure, or baby with a clinical event. So if the EEG not available, then if this event was observed by experienced personnel, including expert neonatologist or a neurologist in the unit watching the patient having this event, then if it is focal, then this is with the possible probable diagnosis of seizures, and this is a level 2 evidence of certainty. If the seizure was not witnessed by experienced personnel, then insufficient data. But if the witness and other seizure type rather than the focal clonic, then probably this is a level 3 of certainty. And this is a possible diagnosis of seizure. If the EEG available, either conventional continuous EEG monitoring or the amplitude integrated. So if it's captured on the continuous video EEG, the conventional one route, and capture event was associated with ictal pattern, this is the gold standard for diagnosis ictal seizure in neonate. If it wasn't associated with ictal pattern, then this is not a seizure. So this event is not seizure, hence does not need to be treated as a seizure. If the event was captured in the amplitude integrated EEG and there is ictal pattern, this is the probable diagnosis of seizures at level 2. And if it's not captured on the amplitude integrated EEG, then this is insufficient evidence and the same as level of the insufficient level by not observed by experienced personnel. So the neonatal seizures are common in the unit with it's up to 2-3 per 1,000 term births, and usually happening in the first few days of life, and mostly caused by acute symptomatic seizures, and usually can be due to neonatal onset epilepsy, and up to 15%. And you can see this is depicting the age representation of the high extreme of the high seizure incidence and prevalence at the extreme of the age. So the commonest cause of the neonatal seizure is the hypoxic ischemic encephalopathy, probably reaching to up to 50% or 47, 60%, 46%. And the second common is the acute vascular injury or infectious diseases. In our country, genetics and metabolic are not rare. So in the hypoxic ischemic encephalopathy, the risk for acute symptomatic seizures around 50%. The risk for epilepsy in those patients around 10 to 20%. In the cerebral vascular insult, the association with the presenting with acute symptomatic seizure up to 70%. And the risk for the epilepsy is around 10 to 30%. In cases with a CNS infection, the acute presentation as a seizure up to 20%. The etiology of acute symptomatic seizures is different, but there is also an overlap. And usually in the HIE patient, the seizure will happen around 6 to 12 hours of age and peak around at 24 hours. And then you can see here in the diagram, there is a trending in the seizure frequency and fading down and disappear within probably 4 days. So you can see this graph is important. And the top here without hypothermia, and the bottom here with the application of the therapeutic hypothermia, where you see can reduce the seizure burden in those patients. The seizure types or seizure semiology in the neonate presenting with the different etiology, you can see here in the HIE group, the commonest clinical manifestation is the clonic type. However, the electrographic seizure is very high, and hence you have to apply the neonatal EEG or the amplitude integrated to capture those seizures. If you go to the preterm, the majority of seizures are electrographics. You have to attach the EEG to these patients. In the genetics, you can see here is the probably tonic seizures or epileptic spasm, a common presentation of those patients. In the infection, also majority of them will have the electrographic seizures. And then vascular, you can see almost half of them will present it as a clonic seizures. So seizure semiology has also may indicate the underlying etiology. So as we are a country of the high consequent marriage, the warning sign for the inborn error metabolism presenting as a neonatal seizure, the seizure begin in utero, or the seizure refractory to conventional anti-seizure medication, or there is a progressive worsening of the clinical and the EEG abnormality beyond day 4. And if there is EEG in the EEG, there is pair suppression or hypsarrhythmia. Or if the MRI is severely enough to suspect HIE, however, the clinical history does not support that. So here's again to represent that HIE can present in the first 24 hours due to the common seizures, and also the common seizure types here in one study included 1,000 patients. The stroke is around 13% and intracranial around 11%. And you can see the infection around 6%. And also the inborn metabolism and genetics around 10% in combination. So the neonatal epilepsy usually started in a study in 611 neonates. And you can see here is the neonatal epilepsy appeared around 13%. And the other etiologies, the epileptic encephalopathy now almost around 2/4, and the brain malformation in 40%. And you can see here is the benign neonatal seizures and syndrome in 1%. So this is the guidelines published by the International League Against Epilepsy in 2023. And it's a consensus among the experts in the field. And you can, so the first recommendation number 1, the first line anti-seizure medication should be phenobarbital, and the strength of recommendation is moderate, and the case-based recommendation is high. So phenobarb, and the level of agreement on the phenobarb as the first line in HIE or stroke or hemorrhage is very high. If there is channelopathy, this is rarely will be known at the time of presentation, even in the second child, that if the family has a known genetic causing neonatal onset epilepsy with a channelopathy, then you can start right away the sodium channel blocker, and the level of agreement is high. So again, this is representing that the recommendation 2 is the the second line after the first line failure is the either phenytoin or levetiracetam. This can be used in same categories of etiology, and the level of agreement is high, moderate to high, and the level of agreement was high. And in neonate with cardiac disorder, the preferred drugs as a second line is levetiracetam over the phenytoin because of the fear of the arrhythmia and cardiac toxicity. And the third recommendation published in this guidelines is this medication should be discontinued in the patient with acute symptomatic seizure secondary to HIE before the discharge home, regardless of the MRI findings and EEG findings, as long as the seizure was brought under control. And the level of agreement is high. So again, this represents the diagram and the flow from the first line to, and in the second line also to consider the vitamin responsive, including vitamin B, either IV infusion or oral 100 milligram loading, and also the clinical feature of the channelopathy, and also the consideration in the cardiac cases not to combine phenytoin with lidocaine, and a matter of fact, not to combine the two medications together with the presence of cardiac or no cardiac lesion, but to postpone the phenytoin use maybe to the third line in the cardiac cases and go right away with the levetiracetam. And the dosage of the phenobarb, as you know, 20 per kg, and you can repeat if needed. And then the Keppra is around 40 to 60. If it's at 40, you can add another 20. And usually the maintenance around 20 milligram per kg per dose. TID, so 60 per day. And the phenobarb in the neonates and the first week of life, especially with the use of hypothermia, the maintenance will be used usually 5 milligram per kg once daily, and phenytoin twice a day. The treatment of early onset epilepsy syndrome, usually acute symptomatic cause of neonatal seizures, is ruled out, and consider early vitamin responsive, especially after the failure of second line. This is the highly strongly suspected channelopathy, or there is a family history suggestive of that, to initiate the sodium blocker, usually starting with IV phenytoin, then switch to oral carbimazepine or ex-carbimazepine. So the treatment, rapid treatment of onset probably does not affect the seizure burden or long-term outcome, but the neonatal who present with these kind of seizures and in the absence of acute symptomatic cause should be discharged on medication, or usually multiple medication, 2 or 3 medication. In those cases where you need to involve the genetics, the neurologist in the early course of the treatment. Usually, neonatologists will need help in either investigating those patients or the selecting, adding a third line or fourth line of the anti-seizure medication. So usually the unfavorable outcome associated and related to the cause of the seizure, not probably the seizure burden only. And usually this is often have a multiple comorbidity. Seizure burden in the HIE survivor with a severe clinical seizure burden compared with those with HIE who remains seizure-free, and there is a drop in the IQ at the age of 4 years. So treating seizure is important, has impact even on the same patient with the same etiology, and even after the adjustment for the MRI detection lesion on. So postnatal epilepsy risk factor. Presence of status epilepticus alone is a risk factor, but multifocal versus focal also carry a risk factor. Seizure split to contralateral hemisphere, these are important in the EEG findings. And the clinical, the prediction for the epilepsy is more than the use of more than 2 medication, the severity of the encephalopathy, and also the semiology other than clonic, focal clonic seizures, the abnormal neuroimaging or low birth weight. Those patients have a higher risk for developing epilepsy later. And this is a combining various study with the study patient with the clinical and EEG. And you can see the prevalence of epilepsy in those patients variable from 18% to 48%, commonly around 20 to 30%. So what you see clinically usually in the neonatal seizure is the tip of the iceberg. And this is also the another publication by the same group of the International League Against Epilepsy, identifying the epilepsy syndrome occurring in the neonatal period. So in the seizures on the EEG, you can see apparent around with subtle around 30%, but 70 to 80% usually they will go unnoticed, especially with patient severe encephalopathy or severe HIE, or a patient in the cardiac unit, or he is a major cardiac issue and sedated or undergoing cardiac intervention. So why we need to monitor those patients and to detect the seizure or the electrographic seizure? Because there is a study animals prove that there is reduced density of the dendritic spines in the hippocampal pyramidal neurons, decrease in the neurogenesis, delayed neuronal loss, and change in the hippocampal plasticity. And all this lead to the impaired learning and memory. So the presence of the clinical description or semiology alone is not enough, because this here clinical scenario can be seen with seizure or without any seizure as the underlying. So why we need amplitude integrated EEG? Because the conventional continuous EEG is not available in every unit, and if it is available, need a high trained staff and also time consuming. So that's why we need the amplitude integrated neonatal EEG. And the CFM, or the amplitude integrated EEG, has a high detection rate if this reviewed by experienced user, trained user, and also use real-time EEG displays or the last line, which indicate the raw EEG activity. Important to differentiate between artifact and what is seizures. And they monitor central temporal region, and bilaterally monitoring the number of electrode applied, 3 to 4, and high frequency seizure. If the frequency is occurring high, then this will be easy detected on the amplitude integrated EEG. Also, longer duration of the seizure can be detected easily and with high amplitude and bilaterals. However, the absence of these making the detection is less. So shorter seizure, low amplitude seizure, or only focal seizure make the detection by the amplitude integrated is extremely rare. So that you need the conventional EEG also to, if the amplitude integrated does not show any seizure, then you need to call for the conventional EEG. So this patient admitted in a secondary care hospital, but they don't have the EEG, the conventional EEG available in the unit, and they don't have mobile portable EEG machine to be delivered to the unit. But luckily they have the amplitude integrated EEG. So this patient admitted on this month, 8th of November, a week ago, referred from private hospital at age of around 5 hours, was post-dated, delivered by cesarean section with a history of PROM 3 days. So when delivered by cesarean section due to severe fetal distress, and the Avogadro score was low, pH was 7.09, and upon arrival to the hospital, he was having a hypoglycemia, and also when he reached to the unit, after the correction of the hypoglycemia, blood pressure was maintained, and temperature was 34 degrees. So that's a relative passive cooling. And patient was severe encephalopathic with clinical seizures. And his echo later showed a severe BPHN secondary to meconium aspiration with prenatal asphyxia. Patient started immediately on therapeutic hypothermia and connected to the amplitude integrated EEG. They'll see these are pictures from bedside. And if I zoom here, I don't know if I can. So this was on left on day 9, and you can see still having these very frequent seizure. And here below where the cursor is showing here is the ongoing spikes with seizure ectal pattern on the raw EEG. And you can see here is how to identify the seizure. If there is rapid rise and from the bottom baseline and also the upper limit of the activity. And you can see this like the sawtooth appearance of this repetitive cluster of seizures. And later, after seizures subsided, the patient needed a phenobarb loading Kibra and also maintained with the midazolam up to 280 microgram per kg per hour. And you can see here is there is a flattening of the EEG, and you can see most of the activity is around really very low voltage. So that's a bad sign in the first few days of life. Do you see my slide? Okay. So now this is done on, I think here on day 14, so a few days ago. And you can see patient already, the background of the amplitude degree is falling below 5, and the upper limit is markedly below 10. So the normal, we'll discuss it soon. You can see this suggests severe suppression burst, and the burst is really very tiny. It's not exceeding 10, so this is a suppression pattern more. And you can see the raw data here is around 0. So that's another bad sign on day 4. So this is the normal in the top, what you expect to see. The lower margin should be above 5, and the upper margin should be above 10. I can see here the cyclic. You can see during sleep there will be drop around here 10 microvolt, while most of the time is this. So this is a continuous normal voltage EEG tracing, and this is the one you want to see in the second or third day in a patient with HIV after treatment with the therapeutic hypothermia and controlling the seizure. However, most of the time you have this continuous normal voltage, which is moderately abnormal, where the lower amplitude is falling below 5. However, the upper margin remain above 10. This is the bad ones, where you see the amplitude of the lower is below 5, and most of the time the upper limit is below the 10. And here is almost a flat tracing. So the MRI, MRI pattern is usually distributed like you can see in the neonate full term in the basal ganglia thalami, and also in the preterm you might see cortical and periventricular changes. So these are the MRI expecting to see in those patients. I have to finish quickly. I know I'm approaching the end of my lecture. So the second is another to represent the other extreme of the neonatal onset epilepsy, where you can see this is a 17 days when he's referred to the tertiary care hospital, and seizure onset at day 2, and there is no clear risk factor, and the MRI was unremarkable, septic workup was unremarkable, and the seizure type was described as subtle seizure, dystonic posturing, and
دكتور علي معلش ميوت يور مايك. شكرا.
Okay, so shall I end my presentation? I think I have 1 minute.
No,
Okay.
I was speaking to Dr. Ali Abd.
Okay. So we connect the patient for the EEG, and you can see this is a conventional EEG. We'll see the seizures coming here from the right side, and then go to bilaterally and continue to have this. So this is a most likely patient with channelopathy where they continue. And also the advantage of the conventional, you can identify even focal pathology. Like here, you can see asymmetry of this discontinuity. This can be associated with a left hemispheric stroke, where you see the seizure can happen here, or even the attenuation can happen. But also this can be seen in other type of epilepsy, especially the genetics, where you see asymmetric attenuation. And this is the usual severe birth suppression pattern in the patient with epileptic encephalopathy or patient with severe HIE. So before discharging the patient, especially if a patient was medication was discontinued, there is a high risk for the developing epileptic encephalopathy, especially the infantile spasm. And infantile spasm, the medication should be commenced as soon as possible of the appearance of the hypsarrhythmia or the spasm, clinical spasm. So who are the risk factor for the developing the infantile spasm? Those are the, number one is the severely abnormal EEG at day 4, or with the seizure recorded on the EEG at that day, or deep gray or brainstem injury on the MRI, or there's an abnormal tone on discharge on the examination. So that's the 3 risk factors of developing probably nearly future epilepsy. And the combination of these, the 3, make the probabilities around 57%. So if you have a patient who have seizure on day 4, and the EEG was not normal that day, and the MRI showed moderate to severe injury, and the patient was having hypotonia or hypertonia on the discharge. Mostly, if patient stayed 2-3 weeks, it will be hypertonic. And those patients, you need to teach their family how to recognize the infantile spasm. And one way I do usually, I show them a video and I keep in my Twitter and I just play the video and show it to the mother, and I instruct her if she see this pattern, she should come immediately to the emergency room where the patient can be admitted or commencing the treatment. And by this, I end with this summary that the clinical observation is unreliable for identifying the seizures. In neonate, the newborn typically have high seizure burden, and most neonate seizures have an acute symptomatic seizures. And if the seizure persists beyond day 4, this you have to think of another etiology, because most of the seizures related to acute symptomatic will subside within a few days. And the seizure treatment should occur in tandem with an expedite evaluation for the seizure etiology. So you saw the seizure, treat or confirm and treat, and then continue investigating. And the electroclinical seizure can become subclinical after treatment is initiated. That is due to uncoupling and because of also the GABAergic response in the cord more than in the brain. So the seizure will be activity is continuing on the brain while you didn't see any clinical movement in the limbs. The duration of treatment depends on the etiology, and you should follow also the guidelines published recently. Thank you so much, and I'm open for questions. I have 1 or 2 minutes.
احنا will give end of the session time for questions if we have. Right now we don't have actual, but maybe after the presentations we will give.
Okay.
If you want to leave us, we can send it on your WhatsApp and we can take the answer if you are busy.
I will be around, but if I wasn't around, then you can send it on the WhatsApp. Okay. Thank you.
Okay. Thank you.
There is there is a change in our schedule as Dr. Tariq has an ongoing surgery now, and he will join us later. Now our neonatal physiotherapy specialist, Dr. Nada Ahmed Al-Qadi, will give us a presentation about sensory motor integration approach and pediatric rehabilitation. You can share your screen, Dr. Anada.
Doctor, unmute, please. Dr. Nada, unmute, please. Dr. Nada, unmute, please, Dr. Nada. دكتور ندى unmute بليز، صوتك مطالع. ممكن تعيدي من الأول دكتور ندى؟
Thank you very much, Dr. Nabil and Dr. Samira, for this opportunity to take a part in this amazing sensory motor integration approach. What is the available pediatric school in the rehabilitation? Number 1, NDT. Number 2, DMI and CME. Number 3, aquatic. Number 4, suit therapy. Number 5, spiders. Number 6, mastigover. Remember that the hippotherapy and sensory integration don't be considered as independent school. Neurodevelopmental treatment, NDT, aims to improve functional ability by addressing movement patterns and coordination issues. It emphasizes retraining normal movement pattern and integrated these patterns into daily activity. Treatment plans are developed based on the thorough assessment of patient motor skills, sensory perception, and cognitive function. Facilitation and inhibition. Techniques are used to facilitate normal movement patterns and inhibit abnormal tones. This involves guiding the patient movement and providing sensory input to promote more efficient motor control. Dynamic movement intervention. DMI target to the acquisition of autonomic posture response and promote the development of gross motor milestones, including rolling, sitting, crawling, in transitional movement, standing, skills, and walking. The goal of DMI to elect a constant and specific active movement response from the child by completing an exercise using a dynamic handling technique. DMI treatment focuses on the concept of neuroplasticity. Neuroplasticity is the brain ability to sense current and create new motor pathways in the brain using repetitive movements pattern. Aquatic exercise in the waters appeal to children with CP because of the unique quality of buoyancy of water that reduces joint loading and impact, addressing the negative influences of poor balances and poor posture control. Suit therapy is a form of therapy that helps individuals with cerebral palsy by promoting proper muscle function and control. The method involves specialized suit worn by the individual, providing sensory and proprioceptive feedback to the muscle. It helps to improve body awareness, balance, and coordination. The suit has multiple adjustable rings and elastic bands that are adjusted to provide pressure and support to the muscle group and joint affected by cerebral palsy. Mastigover. Neurosensory motor reflexes integration. It uses neuromodulation technique that pave and reroute the nerve pathway of primary reflexes patterns to bring them into a state of proper neurophysiological function, which improves the balance of excitation inhibition process of the nervous system, increasing the hypothalamic pituitary adrenal stress resilience and neuroplasticity. Hippotherapy. It alternates a form of therapy that uses horses and equine equipment to help children with cerebral palsy. It can help a child to improve physical function and mobility. It can also help children with cerebral palsy cope with emotional challenges and build up self-confidence. Hippotherapy can improve gross motor function and balance in pediatric CP. Patients with adverse effect. Patients with cerebral palsy have been shown to have interest motor and neuromuscular re-education outcome with the hippotherapy. While hippotherapy is generally safe, it may be not ideal for children with severe epilepsy or who are fearful and allergic to horses. How we can choose a suitable school. You choose a pediatric school based on your assessment goal. So you decide your goal first, then you design your program and pick up the best school for your aim. CB is a static entry to the brain occurred before, during, or after delivery until the age of 3 to 5 years in immature brain. And there is no muscle weakness because it's upper motor neuron lesion. The primary complication of CB is loss of selectivity, alternation of tone balance problem. The sensory complication are liver arm dysfunction. How we move? We move because there is an aim. We move for either internal or external aim. There are a lot of theories that try to explain how we move. The best theory is the motor planning theory. The motor planning theory sensing occur by peripheral receptors, perceiving occur first and second sensory cortex, interpreting occur by higher level sensory processing areas in the parietal and occipital lobes, and conceptualization prefrontal cortex and other higher level association areas. The strategy and the plan occurred by supplementary motor cortex and basal ganglia and cerebellum. The activation occurred by motor cortex, basal ganglia and cerebellum. The execution occurred by motor neurons and muscles and joint. Reflexes related to the movement. We develop our skill in normal by the assist of primitive reflexes. They are quick, stereotype, very considerable. Respond. We can classify them by their role in developing. Number one, in apedal creators, the spinal and brainstem reflexes have the major role basic contraction control. In the quadrupedal creator, the midbrain reflexes have the major role writing. In the bipedal creator, the cortical reflexes have the upper hand protective and equilibrium. Sensory processing in normal situation. Normal situation information received, then the information travels to the brain, then the brain processing this information, then the brain creates a plan, so the body executes the plan successfully. In abnormal situation, information received, then the information travels to the brain, but the brain misinterpreting this information, so the brain creates blank with bad data, so the body executes this bad data or shut down. Sensory processing disorders. It is a neurological condition that exists when the sensory signals don't get organized into appropriate response. People with sensory discrimination processing disorder find it difficult to processing sensory information like sound, touch, movement from the world around them. This means that they maybe feel sensory input more or less than other people. Sensory processing disorder can therefore impact on the person's ability to interact in different environments and perform daily activities. There are three types of dysfunction of sensory integration. Number one, sensory modulation disorder is the problem with turning sensory messages into the cortex in the controlled behavior that match the nature and the intensity of the environment and sensory information. Number two, sensory-based motor disorder is a problem with stabilizing, moving, or planning a series of movement and responding to sensory demand. Number three, sensory discrimination disorder is a problem with sensing similarities and differences between sensations. Sensory modulation disorder is a specific component of sensory processing and related to the brain ability to respond appropriately to the sensory environment to remain an appropriate level of arousal or alertness. For instance, while reading this article, ideally your brain is memorizing the words on this page. This is the visual input, while inhibiting inputs from the other sensory systems such as the feel of your body, weight on the chair, or non-relative sounds on your environment. This allows you to focus if you are struggling with modulation at this moment. The two different responses. Number one, over-responsiveness is characterized by an exaggerated response to the nervous system to sensory input. One common type of over-responsiveness is motion sickness. People who are over-sensitivity to their vestibular senses may develop motion sickness as they respond to fast movement. During an over-responsiveness behavior, the sensory system goes to fight and flight mode when there are no real danger present, by the brain perceives it as such. They feel as if they are being constantly bombarded with the information. Common symptoms of over-responsiveness: infant fatigue, delayed motor skill, startless, doesn't like tags or certain fabrics, doesn't like washing hair, combing hair, brushing teeth, overwhelmed, crowding, and noisy environments. Number two, under responsiveness is the opposite of the over responsiveness. This is the lack of response to the environment stimuli. Children might check out or daydreaming, or they are very unconfused on what happened around them. They also tended to be uncoordinated and maybe have difficulty with fine motor skills. The common symptoms of under responsiveness: delayed motor skills development, drooling and lack of response to sight and sound, daydreaming, checked overweight and high pain tolerance, doesn't notice that the cuts and the breaks, slow muscle tone, bad posture, clumsiness. Sensory-based motor disorder. Children with sensory-based motor disorder have hard time coordinating their brain and the body. Normally, the brain receives sensory messages, sensory input, and produce an adaptive response. This is the motor output. When a child suffers from sensory-based motor disorder, the response incorrectly to the surrounding environment, whether it's by not understanding the space of around them or inability to move the body in the right way. There are two components of sensory-based motor disorder: dyspraxia and posture disorder. Dyspraxia comes from Latin word praxia, to do, and dys meaning badly. Children that suffer from this condition have a hard time processing environmental stimuli and following through with the motor action. They will usually have a poor motor coordination, timing, planning, organizing, and sequencing. Most kids will prefer sedentary activities and may be more imaginative to hide their lack of physical skills as compared to their classmates. Common symptoms of dyspraxia, including difficulty handling scissors, eating utensils, and other handheld devices, different buttoning, zipping, and other fine motor activities, difficulty dressing themselves, illegible handwriting, poor hand coordination, difficulty navigating through a crowding, ability to learn the complex sequence of movement, anxiety walking or up or down stairs, visual perception issues, including crossing the midline, taking the left hand and putting it on the right shoulder, or reading from the left to right. Posture disorder deal with the children's ability to operate their muscle and movements and move their own body successfully. Children have difficulty keeping their body on task while moving or keeping their bodies still at rest. Common symptoms of posture disorder, including frequently drooling, inability to keep things in the mouth while eating, not chewing the food good, poor depth perception, and difficulty focusing eye or trouble aim when reaching for the object. Poor sports performance, difficulty maintaining balance for a long period of the time, frequently leaning on the chair or wall, very clumsy sits and walked position, slow muscle tone, difficulty using the restroom. Sensory discrimination disorder is the ability to brain to interpret information and disagree the relative information. As a disorder of discrimination means the brain sometimes jumps or confuses the information. Children that suffer from the sensory discrimination disorder often have a hard time perceiving information. Physiotherapists may be involved in the helping the individual with sensory discrimination disorder, improving their ability to process sensory information related to their body and environment. Can play a role in how person experienced and responded to the physical sensation, movement, and body awareness. How the physical therapy can help. Number one, by perception and body awareness. Proprioception refers to the body ability to sense its position in the space. People with sensory discrimination disorder often struggle with the proprioceptive input, which can affect their balance, coordination, and motor skill. Sensory perception refers to the input from the one muscle, tendon, joints, and ligament, also known as the position sense, and it's responsible for internal perception of body position and force exerted. For example, proprioceptions are facilitated via stretching, lengthening, compression, shortening, and control one's muscle, and contraction one's muscle. They are functionally recruited during the resistive or heavy work. Activating perception works up the muscle, increasing motor responsivity and gaining motor control, coordination, and strength. A best source of sensory input to help with the sensory moderation and regulation disorder facilitates the release of serotonin, which is the master regulator key in the central nervous system, as well as dopamine. Serotonin is a coping chemical. It breaks up dopamine to prevent hyperactivity and overprocessing of information, resulting in natural state. Serotonin also helps set the firing level for all neurotransmitters if released suddenly, a large amount to the brain, responding with epinephrines, which may create emotional highs. Self-injury may also cause the release of serotonin and maybe contribute to pitching, pinning, hitting, and head banging. In addition, aggressive behaviors are often met with proprioceptive and deep touch inputs, holding down firm grip. Proprioceptive activities like joint compressions, carrying heavy object, pushing heavy object, pulling or pushing another individual on a scooter ball, crab walking, bear walking, wall pro walking, push-ups, hanging from monkey bars, crowding on all four, jumping on a trampoline, running, therapy ball, theraband activities. Vestibular system. Our vestibular system responds to changes in the gravity and therefore activated by the movement, contributing to arms balance and muscle tone. Movement generally has impact on arousal living and may be used to facilitate climbing or alternating response. Vestibular inputs may be linear equipment suspending from two suspension or angular from one suspension or rotatory around one axis and may be delivered in horizontal, vertical, angular blend, which receiver in upright, inverted, prone, supine, side-lying position. Each type of movement plan and plan of movement and position of the receiver will have individualized effect. The most powerful and longest lasting sensation may be last from 4 to hours from 4 to hours 8 after spending 15 minutes on swinging hang from the to suspension. Point in linear direction causes a very strong brainstem sensation, which is the best if done, followed by proprioceptive. Before cortical task, in order to help the brainstem focus on autonomic function so the cortex and can adequately learn 45 minutes to hours before a task, shown to cause a release of neurotransmitter is histamine, is known as to alter the central nervous system, which is allow for more efficient sensory processing. Vestibular activities bouncing on therapy ball, being pulled on a scooter ball, rocking a chair, and these modalities. Tactile input. The tactile system is one of the largest sensory systems in our bodies and play an important role to ability to interact with the environmental around us. The tactile system is responsible for our ability to recognize the quality of objects such as hard, soft, sharp, dull, rough, smooth. The tactile system also provides us with information about the quality of touch we are received. Some people who are hypersensitivity and overreacted to tactile, and other people who are hyposensitivity and underreacted to the input in tactile input. Deep touch is coming while light touch is alternating and maybe result in protective or advanced response. Light touch can cause the release of arousal brain chemicals, cortisol, adrenal, sympathetic nervous system fight and flight response, which may be result in aggression or hyperactivity. Deep pressure touch inputs such as massage, squishing, and squeezing facilitate the release of dopamine, activating the parasympathetic nervous system for relaxation and natural homeostatic, which may be wash away cortisol and adrenal involved the fight and flight response of the outcome nervous system. Too much dopamine may increase the hyperactivity and may be regulated by increasing the serotonin level via proprioceptive inputs to the muscle and joint. It's imperative not to force his or her interaction with an anxious input, as stress associated with his or her resistance will impede progress and novel learning from occurring. This is the tactile activities. Okay, number 4, motor planning and coordination. For example, practicing everything like walking, climbing stairs, using games and activities that involve tracking movement. Number 5, sensory integrating sequence in. Last example like using music or club to help individuals coordinate movement with exercise from percussion. Number 6, movement related and functional skills. Number 7, posture control and stability. Number 8, pain management and sensory sensitivity. The conclusion: you choose your pediatric school based on your assessment goal. So you decided your goal first and then design your program and pick up the best school for your aim. Physiotherapy play an important role in helping individuals with sensory discrimination disorder, improving the physical function, body awareness, and the ability to manage sensory input flow. sensory input in a more adaptive way. Through the target intervention, physiotherapist helps individual build up skills to better interpret sensory feedback, improving movement pattern, and enhance the quality of life. If you suspected yourself in sensory discrimination disorder, a physiotherapist, especially with one experience in sensory processing issue, could be instrumental in providing appropriate treatment. Thank you for your good listening.
Thank you, Dr. The next speaker will be Professor Stephanie Politz from my clinic. Will speak about NEC treatment for surgical versus bedside drainage in extremely low birth weight. Is Professor Stephanie with us? Yes. Hello, welcome, Professor.
Hello, thank you
Hello.
for the opportunity to present here. Are you able to see my slides?
You can just, yes, now it's okay.
Okay. Wonderful. Okay. I'm a pediatric surgeon at the Mayo Clinic in Minnesota in the US, and I'm grateful to be able to speak to everybody today about the management of necrotizing enterocolitis in extremely low birth weight infants. So for some background in epidemiology, this occurs, necrotizing enterocolitis, or NEC as I'm also going to call it, occurs in about 10% of extremely low birth weight, meaning less than 1,000 grams, or very low birth weight, less than 1,500 grams. And in the extremely low birth weight infants, it typically occurs after 1 week. The necrotizing enterocolitis that occurs right away is more frequently in older term babies. It typically occurs in infants who have already been enterally fed. And then there are some risk factors associated with it. Prenatal risk factors include absent or reversed end diastolic umbilical artery flow, maternal eclampsia, fetal distress, and premature rupture of membranes. Comorbidity in the infant themselves that can be associated with increased risk of NEC are asphyxia at birth, hypothermia, respiratory distress syndrome, which happens a lot in infants who are premature, apnea, congenital heart disease. This is a big risk factor, especially for term babies. When necrotizing enterocolitis occurs in infants who are not premature, it's often in the setting of congenital heart disease. PDA, a large persistent ductus arteriosus, and likewise, if indomethacin, which is sometimes given to close the, or indomethacin can also be associated with NEC. And then infants who are born with gastroschisis or Hirschsprung's disease are also at increased risk of NEC. So especially in gastroschisis, that's something to keep on your radar when treating those babies, that they can also get necrotizing enterocolitis. The pathophysiology is not entirely understood, but it's thought to be related to a few things. First, the motility of the GI tract develops largely in the 3rd trimester, much later than the intestines develop themselves. And so infants who are born premature do not have mature GI motility, and therefore it leads to stasis, and we think makes it more prone to bacterial translocation. The mucin border of the inside of the intestine is also not well developed, and that's thought to protect against translocation of bacteria, as are the tight junctions, which are similarly not well developed in premature infants. And then there have been various growth factors and cytokines, which are either up or down regulated in infants with NEC, but we don't know yet whether these are cause or effect. Prevention is a big component of the medical care of premature infants. The most common thing is use of maternal breast milk rather than formula. This is standard of care now, and donor breast milk is used when needed. Antibiotic stewardship and not utilizing antibiotics unnecessarily. The microbiome in these neonates is also immature, but giving antibiotics makes it even more difficult to have microbiome that will protect against NEC. Minimizing acid blockade, which similarly disrupts the microbiome, and then judicious transfusion. Extreme anemia is a risk factor for necrotizing enterocolitis, but at the same time, transfusion also is immunomodulatory and should not be used unless absolutely needed. And then over on the right, I have some more relative potential prevention strategies. Probiotics have received a lot of attention in the literature, and there are a lot of studies showing a benefit to them. However, there's no universally agreed upon dosing. So right now, it's not necessarily considered standard of care, but it continues to be studied. Fortification, so many times these neonates need additional calories to maintain good growth. So there's been a lot of studying human-based milk fortifiers versus bovine or other milk fortifiers. And there was recently a large study published in The Lancet, which did not show any decrease in NEC when human milk fortifiers were used as a result, as opposed to non-human milk fortifiers. It doesn't really answer the question whether fortification itself, so just increased caloric intake and exposure to the gut increases the risk of NEC. And then CPAP has also been evaluated, nasal CPAP specifically, and there's some retrospective data suggesting that it is associated with an increased risk of NEC, but this is not conclusive, and certainly CPAP is still used. So these are the Bell's criteria, which are what we use for both diagnosis and also to determine the severity of necrotizing enterocolitis. Stage 1 is oftentimes where you're not totally sure. The infant may be showing signs that something is wrong, but it's not definitively necrotizing enterocolitis yet, especially if there's not gross blood and stool. Typically, stage 1 is managed medically. The surgical team, at least in our practice, is typically involved when there is Bell's stage 2 necrotizing enterocolitis, and there's pneumatosis identified on the x-rays. And then stage 3 is more severe, and that's where the child is obviously systemically ill. Thrombocytopenia, which can occur in Bell's stage 2B and stage 3, is a really helpful sign in determining the severity of the necrotizing enterocolitis. We often see a downtrend in the platelet count in our babies, especially if they develop a surgical indication. So this is an example of an x-ray of a patient with pneumatosis intestinalis. You can see the bubbly lucencies in all of the bowel loops, and that is pretty pathognomonic for NEC in a extremely low birth weight infant. So treatment, the mainstay initially is medical therapy, and this includes bowel rest, so stopping enteral feedings right away. These extremely low birth weight infants cannot go without nutrition for very long, so that typically is accompanied by starting TPN, and central access is needed to do so. Extremely low birth weight infants need a PICC line or some type of central line to give TPN. Decompression is also part of our standard management. On the right is an example, that's a Rapogal tube, but a suction catheter with a sump port to decompress the intestines, but the sump port allows air to come in constantly so that the tube doesn't get stuck up against the mucosa and cause too much irritation. Initiation of antibiotics. And we typically use Zosyn and initially vancomycin, but that can be taken off soon. I'll talk about antibiotics a little more later. And then serial exams and x-rays. So for an infant newly diagnosed with necrotizing enterocolitis, or if we're very worried about them, we will typically get a 2-view x-ray, so a supine and a left lateral decubitus x-ray every 6 hours. As we become more reassured by their progress, we will space that out. Indications for surgical intervention is always a big question when caring for these infants. There are absolute indications as well as relative indications. The absolute indications are evidence of a perforation in the bowel, which can be diagnosed either by pneumoperitoneum on the x-ray or by a positive paracentesis. So if there's ascites that is drain aspirated and it either looks like frank enteric contents or it has a positive Grand stain, that is very concerning for perforation. Additionally, abdominal compartment syndrome is also an absolute indication to operate on the child, and that would be when they're in respiratory and or renal failure or refractory hypotension due to a large distended abdomen. You have to open that abdomen to decompress it, or they likely will succumb to the illness quickly. That's a true emergency. And then the relative indication. So refractory sepsis. So if an infant is being treated medically for neck and continues to be thrombocytopenic despite transfusions, requires pressor requirement, high ventilatory needs, and there's no real improvement, that may be a sign that there is necrotic intestine. And so after a thorough discussion with the neonatology team and the patient's parents, we sometimes decide to do an operation to check for this in these infants. And then other relative indications are a fixed loop. So on an X-ray, if there is a loop of intestine that is not moving over the period of several X-rays, that is associated with that loop being necrotic. Abdominal wall cellulitis. This is definitely a relative contraindication. I think you read somewhere that it's an absolute, but I can tell you that we often do not operate based on this alone. Just the inflammation of the intestine alone with the extremely low birth weight infants' thin skin and abdominal wall can cause redness. But that doesn't mean that there's a perforation or even necrotic intestine. So that's just one helpful piece of information, but it needs to go along with everything else. Similarly is the case for a palpable mass. It may be another piece of information that will help us make our decision, but we typically don't do an operation based on that alone. So this is an example of pneumoperitoneum, and on the film on the left, it's very subtle. It doesn't present with the classic air under the diaphragm as pneumoperitoneum presents in older patients. We call this the football sign because you generally see a central round or oval area of pneumoperitoneum, and it has arrows on it there. And it takes an astute radiologist or whoever's looking at the film to pick this up sometimes. This is also why we recommend getting the left lateral decubitus position, because it is much easier to see this air when it redistributes over the liver there. This is the same patient, and these x-rays were taken at the same time, but it's a lot more obvious on the lateral film. So in extremely low birth weight infants, the question when there is pneumoperitoneum is, do you place a drain or do you do an operation, which is typically a laparotomy? This has now been studied by several really well done randomized controlled trials. The first one that everybody knows is the one by Dr. Moss and team, published in the New England Journal in 2006. And most of the patients were in the 800 gram range, so would classify as extremely low birth weight. And they found no difference in ultimate outcomes between the two groups, a drain or a laparotomy. So there was no increased risk of death associated with the laparotomy. A subsequent study published in 2021 in Annals of Surgery, and also a meta-analysis performed around the same time, found similar findings. There was no difference in survival or neurodevelopment outcomes overall. However, they realized they acknowledged that there's likely some bias. There's an entity called spontaneous intestinal perforation, whereby extremely low birth weight infants have a bowel perforation, but they don't have, it's not the same, or we don't think it's quite the same physiology as necrotizing enterocolitis because they're not systemically ill. The rest of the intestine, aside from the perforation, is healthy. And so when they did a subset analysis of patients who had necrotizing enterocolitis rather than spontaneous intestinal perforation. And there was potentially some benefit in the neurodevelopmental outcomes in the patients who underwent laparotomy initially. Also, they found that the majority of the patients who underwent initial drain placement ultimately needed a laparotomy, either because the drain didn't work and they were still sick, or because they developed a stricture. This is an example of an x-ray of a baby with a drain in place for an intestinal perforation. And we typically use the Penrose drain, which is pictured here, and you can cut little slits in it to help it drain better. and it can be placed in the bedside, usually with minimal sedation. And you just make a small incision. I usually get through the abdominal wall and into the peritoneal cavity with a hemostat and then place the drain. The biggest thing is making sure that you avoid the liver, which can be quite large in these neonates. And if injured, the capsule of the liver, it may be a fatal hemorrhage situation. It's very delicate. So you want to make sure that you go low enough on the right side of the infant if you're going on the right side. And then you can even irrigate through this drain a couple times a day with sterile saline if you'd like. And typically you'll want to see the infant improve clinically and that the output clears up. So what my approach is for infants that have pneumoperitoneum, if they're under 1,000 grams, I will typically try a drain first. If they are over 1,000 grams, or if they clearly have necrotic bowel, so it's not just pneumoperitoneum, then I will usually take them directly for a laparotomy. I think it varies by surgeon and even by institution, but I think you just have to figure out an approach that works well for you and your team, and stick with it. This is an example of an infant that we took to the OR, and this would be more of what I would call a spontaneous intestinal perforation. So if you take an extremely low birth weight infant with free air to the operating room and find this, you'll be very happy because this is something that you can fix. The rest of the intestine looks healthy. So depending on what you find, there's several options for management of this. The first I have there is called clip and drop, and that's where the infant is really sick and you see a lot of affected bowel. You don't want to take out too much, and so you would just basically remove the parts that are clearly necrotic and not viable. And we often put clips on the end and then just put all of the segments back in, even though they're not put together yet. And then you would come back again in 24 to 48 hours and hopefully be able to save everything else that is there. But you don't want to be over aggressive on the initial exploration, otherwise you'll be more likely to end up with short bowel syndrome. Most commonly, we're doing a stoma, and that's where you remove the affected portion and then don't do a primary anastomosis, but do a stoma. When you have something like in the photo here, you could consider a primary anastomosis or even a primary repair. And there is increasing literature to support this when there's not a lot of other diseased intestine or a lot of contamination. You don't want the patient to be on a lot of pressors because that would compromise blood flow to your repair. The goals of this operation, and this is an example of an infant who clearly had necrotizing enterocolitis. So all of that intestine looks very sick, and it looks very different than the last picture that we saw. And so when operating on an infant like this, your goal is to preserve bowel length for them long term. If you removed everything that looked ill or sick in this infant, they would definitely be short bowel. So in this child, we placed a silo as a temporary closure so that the bowel could be monitored over the next 24 to 48 hours and then go back to surgery. And a lot of the intestine that initially didn't look well over time looked better and didn't need to be removed. And so temporary closures like this can be really helpful, not only for the surgical team, but for the medical team and the parents as well, because you can really see the process firsthand. You also want to minimize your operative time. These infants are very small. They get cold very quickly and coagulopathic. So I usually try to have them in and out of surgery in about 1 hour. You again want to avoid the liver. The liver is very large and extends low into the abdomen. And if it is injured during surgery, it can be very difficult to stop the bleeding. And then lastly, there is an entity called nec totalis, where all of the bowel is necrotic and cannot be saved. This is a devastating event. And when this occurs, we typically would do a silo or something like this and pause and talk with the family and our neonatology colleagues to figure out the best path forward. Sometimes families choose to transition to a more comfort care approach because the mortality with this is extremely high. And even if the child does survive to discharge, it is a very difficult childhood and life basically being TPN dependent forever. This is 2 examples of babies who received stomas. This is the most common operation that we do for necrotizing enterocolitis. It is a upper abdominal transverse incision And this is important because the umbilical vein, so if the infant has an umbilical vein catheter, a lot of times that needs to be removed, and our additional venous access needs to be obtained because the incision, you can see on the patient on the right, needed to go all the way over to the other side. So that's just something to think about if you're going to operate. If a baby who has an umbilical vein catheter needs surgery, you may need to think about getting different access in case it needs to be removed. And then we typically bring out either end of the bowel into the incision as an ileostomy or jejunostomy and a mucus fistula so that you have access to the distal part as well. There was a recent basically guideline published about use of antibiotics in infants with necrotizing enterocolitis, which I think will be really helpful for the field. And the point of this is to make sure that unnecessary antibiotics are not utilized. And basically, if there is surgical necrotizing enterocolitis on the far right, you can continue it for 7 to 14 days. If it is necrotizing enterocolitis that didn't involve surgery, then you should stop in 5 to 10 days. And if it is just a rule out where you're not sure if they have necrotizing enterocolitis yet, so the Bell stage 1, you can do a shorter course, like 48 hours. So for infants that do require surgery for necrotizing enterocolitis, they most frequently will have a stoma, either a jejunostomy or an ileostomy. This can be problematic for their growth. There is an association, a strong association of having a stoma and poor growth in extremely low birth weight infants. And that is due to the sodium loss that occurs in these stomas. And the interesting thing about this is the infant's serum sodium level will often be normal. So it can be very confusing. So the way to check for this, and we advocate for this to be done routinely, like once a week, is to check a urine sodium. If the urine sodium is low, like less than 10 or even less than 20, that means that the total body sodium is low, and those infants would benefit from enteral sodium supplementation to help with growth. The other thing that you can do to help with growth and to help get the sodium back in is refeeding. And you noticed in the photos, the infants had 2 stomas. They had the mucus fistula as well. And so that allows for refeeding. So the contents that come out of the ileostomy or jejunostomy can then be put back in through the mucus fistula through a syringe or even a pump. The tricky part about this is placing that catheter, as you can see in the photo here. That can be really difficult and it's not always possible. But when you are able to do this, it allows the infant's distal bowel and colon to be used, which improves their nutrition. And then it also decreases the rate of anastomotic leak and helps increase decrease the time it takes for them to have return of bowel function and tolerate enteral nutrition after the stoma is taken down. And so for stoma closure in babies who require this for neck, we typically wait at least 8 weeks. Sometimes I'll wait longer depending on how inflamed it was and what else is going on with the infant, if they have other comorbidities such as a PDA that needs to be closed. But 8 to 12 weeks is the standard. You want them to be at least 2 kilograms. You want to do the refeeding if possible before. And then you need to get a contrast study to make closure. And so we typically do a contrast enema shortly before the stoma closure surgery is scheduled. The outcomes of necrotizing enterocolitis, sadly, still 20 to 30% mortality. The other potential risk factors are a short bowel syndrome if they lose enough intestine, TPN cholestasis, so this is improving with the advent of newer TPN approaches that cause less injury to the liver. And then neurodevelopmental dysfunction longer term is also a risk in extremely low birth weights who develop necrotizing enterocolitis. And due to the difficulty following these patients long term, it's probably underestimated. That is all I had to present. I again thank you for the opportunity, and I'm happy to take any questions. I also have my email here, and I'm always happy to, if I can ever help anyone, please let me know.
Thank you so much, Professor Stephen. Excellent. I have just 2 short. I just want to ask in IC, are they using analytics and analytics as a routine of NBC?
Having a little bit trouble hearing you. It's very quiet.
Oh, now it's good?
That's better.
Okay, I just wanted to thank you much for your nice presentation. I just want to ask, in my clinic in ICU, are they using routine prebiotics and probiotics for prophylaxis of NEC? That's one point. The second,
Which
if you
type of
will put,
prophylaxis?
yes, they are routine using.
Sorry, I really can't hear you very well.
There is a problem here. Just wait. Is it better now?
Yeah, I'm gonna turn mine up. Yes, that is a little better.
Okay, I just want to ask, in my clinic in ICU,
Mhm.
they are routinely use probiotics and prebiotics for prophylaxis in NIC.
We are not routinely using them, no.
Good. The second thing, can a bedside drainage be the final solution, or it must be followed by a surgical?
No, we think that in about 30% of infants, the drainage is the final solution. So that is why I do it in infants who are still less than 1 kilogram, because in 1/3 of them, that will be the only thing they ever need. And that is really nice for them. It's just more that if you decide to do a bedside drainage, you still need to watch that infant very closely and have a low threshold to operate on them if they don't get better.
Okay, thank you so much.
Thank you.
Thank you. So we'll just stop sharing. Now we'll just take 5 minutes break and continue with the next session. Yes, Zara?
Okay, doctor. يعني we'll take a break now for how many minutes?
Just 5 to 6 يعني we'll start on time again 45.
Okay, doctor.
يلا okay, thank you.
لا.
Can we start again يا دكتور علاء أستاذ علاء؟
تفضل دكتور.
طيب our next speaker will be Dr. Fahd Al-Habshan, pediatric cardiologist. Dr. Fahd is a consultant pediatric cardiology, the National Guard, and he is chairman of the pediatric cardiology division in National Guard Hospital. Dr. Fahd will speak to us about pediatric cardiac emergency. تفضل دكتور فهد.
Assalamu alaikum.
عليكم
Thank you very
السلام.
much, Dr. Nabil, for this introduction, and congratulations for this nice conference for you and the rest of colleagues at Saudi German Hospital in Riyadh.
شكرا جزيلا على
Really
مشاركتك.
nice and well done job year after year.
الله يكرمك شكرا جزيلا.
So the task I was given is to speak about the pediatric cardiac emergencies, and I'm going to share my slides. Can you see that?
Yes.
Yes. Okay. So the aim of this presentation is to increase the awareness about some of the important cases that we may face in the emergency room or during our on-call or during our daily life. I'm going to show some cases, and these cases are real cases. These are our patients, and I did not get anything from the internet or from the books. So just to have a real life practice examples and see how can we manage these cases. So this is the first baby that was brought to our emergency room. He was born in another hospital. He was about 1 week old, and mother noticed that he had difficulty in feeding. He was lethargic, and he had vomiting for 2 days. So this was seen initially in the triage. And then the question always is, how can we proceed when we see a very sick-looking child? Of course, we should always start with the history, getting some detailed history, doing a quick physical examination, and then after that, ordering some investigation. So the history, as mentioned, that this baby was a full term, normal at delivery, everything was fine, went with the mother home, nothing was serious. Only just for the last few days, he started vomiting, having difficulty in feeding, and the baby had no fever. There was nobody who's sick at home, and his symptoms were more of progressive. On the physical examination, this baby was sick. He was pale. He had weak pulses, cold extremities. His capillary refill was 6 seconds, and his heart rate was 200 per minute, respiratory rate 60 per minute, blood pressure was 50/35. So basically, when you are faced with such a baby, you need to recognize that this baby is in shock. And this is very serious, life-threatening condition. And it should be managed immediately. There should be no delay for discussion or consultation because this management is really life-saving. So the management, as usual, with any baby who present at shock or any patient who present at shock, is to start with resuscitation, start with the ABC. Make sure the airway is maintained, check the breathing, check the circulation, and then try to stabilize the patient by giving fluids, by giving inotropes, and then by securing the airway by intubation and ventilation if you think that the patient cannot maintain this airway. And then think about it, why a 1-week-old baby would present in shock. What are the possibilities? The commonest possibility for any disease at any age is the infection, sepsis. Neonatal sepsis should be on top of the list. That's why cultures should be taken immediately and broad-spectrum antibiotics should be started without any delay. And then after that, think about other systems that may cause such a presentation. Part of this is the cardiac system. Other possibilities like metabolic emergency, endocrine emergency, gastrointestinal reflux and reflux disease, could be seizure in the neonatal period. But if we think about the cardiac side, then the most common lesion that would present at this age is a lesion that has systemic outflow obstruction. That means obstruction to the outlet of the left ventricle, either at the aortic valve or more commonly at the aortic arch. And this does not happen immediately after the birth. It happens after a few days because it is related to closure of the ductus arteriosus. Oxygen saturation, because these patients or these babies, they may have differential oxygen saturation. They may have lower saturation in the lower limbs if they have severe obstruction of the aortic arch, and this might be due to the flow from the ductus arteriosus to the lower limbs. If the baby has, for example, a transposition of great arteries with arch obstruction, then the lower limb saturation will be higher than the upper limb saturation. So as we said in the management part, the management is all the same. Remember ABC in capitals, okay? Don't think about which cardiac medication should I start. It is ABC management for a shock. And then after that, think about life-saving medication like prostaglandin. Prostaglandin infusion is life-saving, and it is very important for these patients, even just by suspicion. Even if you are suspicious, don't wait for confirmation, start prostaglandin. Like what we said about the neonatal sepsis, don't wait for the confirmation of other possibilities. If you suspect sepsis, take culture, start antibiotics immediately. If you suspect a cardiac lesion, start the prostaglandin infusion. And then correct other problems like acidosis, electrolyte imbalance, correct the dehydration, and then get in touch with a cardiologist who would give you the definitive diagnosis. And these patients, as we said, with systemic outflow tract obstruction, they can have an obstruction at the outlet of the left ventricle, at the mitral valve, at the aortic valve, or more commonly at the aortic arch. Usually they are well at birth because ductus arteriosus is still open. And then when the ductus arteriosus close, they present usually in shock, like this baby. Usually they have weaker femoral pulses when you examine them as neonates. They would have higher blood pressure than in the upper limb than the lower limb. And more important, the differential oxygen saturation will be evident even from birth. That's why screening for these lesions is very important. And then when you do a chest X-ray for this baby, you may see plethoric lungs, or it can be even normal, and the ECG may show right ventricular hypertrophy. And then, as we said in the management, we should secure the systemic blood flow by initiating prostaglandin to reopen the ductus arteriosus. And then after that, this baby, after stabilization, should be referred to a cardiac center for the definitive treatment, which is aortic arch repair, like in this baby. This case, which I showed you, the baby had coarctation of the aorta. Another case, second case, this baby was seen in another hospital before transferring to our cardiac center. He presented there at the age of 4 months with progressive shortness of breath and feeding difficulties. He was found to have failure to thrive. He did not gain much weight. His birth weight was around 3 kilo. His weight at 4 months was 4.2 kilograms. So he gained only 1.2 kilograms in over 3 months. And on examination, when this baby arrived there, he was found to be distressed with subcostal and intercostal retraction. He had normal heart sounds with a soft systolic murmur. His liver was 3 centimeters below the costal margin, and his ECG showed sinus tachycardia with some LV hypertrophy. This is his X-ray from the other hospital, which is showing clearly cardiomegaly. The heart is significantly enlarged. You see the border of the left ventricle is reaching almost to the border of the chest. And then this baby was seen by a cardiologist in the referring hospital who found this. These are the images that were taken initially, which showed severely depressed ventricular function. This is the left ventricle. This is the mitral valve. This is the aortic valve. And you see that there is severely depressed ventricular function and there is significant mitral regurgitation. So this baby was labeled as having dilated cardiomyopathy with mitral regurgitation and referred to us for further management. This is what we call it the 4 chambers view. And you see the normal right atrium and right ventricle, but the left atrium and left ventricle are significantly dilated. Mitral valve is not moving normally, and there is significant mitral regurgitation. So these patients, we should always think about possibilities. What can cause cardiomyopathy in a child at this age? The most common reasons for cardiomyopathies is like genetic or metabolic disorders, but could there be any other cardiac lesion that may have similar presentation? Always we should check the arch, and these are the initial images that we took for the arch. And if you look at the aortic arch here, the ascending aorta looks good, transverse arch looks good, part of the descending aorta looks very good as well. But we should not trust only the 2D images. We should always switch the Doppler on. You see by color Doppler, there is flow turbulence at the distal part of the arch. And when we measure the velocity is extremely high. It's more than 4 meters per second. The normal velocity is less than 1 meter per second. Here, it's like 4 times higher. So this baby actually had severe coarctation of aorta, and he presented late. So the presentation is late and presented with a picture of cardiomyopathy. So whenever we see any patient with labeled as having dilated cardiomyopathy, we should think about possibility of coarctation of the aorta. And then the management is the same like we said in the other baby. So manage the general status. We may initiate prostaglandin if the baby is 4 months or less, because the ductus may have closed recently and we might be able to open it again, and then refer to a cardiac center for the proper treatment. Next case is another similar case. This was 3 months old baby that was referred to us, and he had excessive crying. He does not settle on feeding as the mother described. She said this baby get worse. He had excessive sweating and poor weight gain, and on examination he was afebrile. Heart rate was 170 per minute. Respiratory rate, he was very tachypneic, 80 per minute. There was intercostal recessions, and the liver was 3 centimeters below the costal margin. This is another X-ray, which is similar to the previous one with significant cardiomegaly, and this is the ECG of the baby. This is our patient, the same patient. So all the cases I'm showing are real cases. So this is the ECG at presentation. So this ECG was interpreted initially as sinus tachycardia. But if we look carefully at V4, V5, the chest leads, V4 and V5, you will see that its ST segment is elevated at V4 and V5. And then if we look carefully at the beginning of the QRS complex in V4 and V5, it is beginning with a deep Q wave. There is deep Q wave in V4, V5, and V6. You see, even in V6, there is significantly deep Q wave, which is also evident in lead AVF and in lead AVL. Actually, it's more evident in lead AVL. And this baby actually was found to have anomalous left coronary artery from the pulmonary artery. So when you see an ST elevation on the ECG, when you see a deep Q wave, always think about anomalous left coronary artery, where the coronary artery comes from the pulmonary artery. And these patients are well in the first month of life. And then after that, with the dropping pulmonary vascular resistance, they get stealing of the coronary circulation from the systemic side to the pulmonary side, and they get significantly reduced ventricular function. And then they develop myocardial infarction. The good thing is that the recovery is very good. These are 4 images for the same patient. These are 4 images for the same baby. The first image on the top left, this is at presentation. The baby had almost no function, severely depressed ventricular function. The second image is just 1 week after surgery. The left ventricle function started to recover. And then this is in the visit like 3 months after surgery. And then the last image is 6 months after surgery. So you see almost full recovery of the ventricular function after the cardiac correction. So that's why these patients, sometimes they are missed and misdiagnosed as cardiomyopathy, while in reality, they have a treatable condition. Next case was another newborn who presented with cyanosis at birth, but this baby was well. He was not in respiratory distress. The main issue was the oxygen saturation of 70%, and there was a significant systolic murmur. This is the X-ray of the baby at presentation, which is showing significantly oligemic lungs. If you compare it to the other babies, Usually, you see the lungs, the plethora of the lung is usually increased in any cardiac condition. In some cardiac conditions, the plethora of the lung is decreased and the lung is oligemic. Sometimes the shape of the heart is abnormal, like in this X-ray. And then if you look at the shape, it looks actually like the shape of an egg, which is sitting on its side. It is called egg on the side heart. So X-ray interpretation is important for these babies because it can give you a clue what is wrong with this baby, what could be wrong that caused that severe cyanosis. Because if you find significant cyanosis in a full-term baby who has no lung problem, the lungs are clear, and there is a murmur, then think about cardiac problems more than respiratory problems. So usually these babies, they have murmur at birth, they have cyanosis, no significant respiratory distress or minimal respiratory distress, but sometimes they may present with sepsis-like picture. Later on, children with congenital heart disease, usually they have feeding difficulties, they may have failure to thrive, they may have increasing shortness of breath and respiratory difficulty, and sometimes they may present in shock if they have a ductus-dependent lesion. The physical examination at birth is very important for the assessment. That's why we should always look, is the baby well-looking, unwell-looking, is he cyanosed or pink? And we should always try to get a good light when we look for that. And then we should check the upper limb and lower limb pulse and blood pressure. So, and not only pulse feeling, but also pulse oximetry, because pulse oximetry assessment is very important to rule out major or critical congenital heart conditions. And then examine the precordium for possibility of murmur. The hyperoxia test, just to alert people, should not be used nowadays in the presence of good pulse oximetry tests. This test should not be used. It used to be done long time ago, where you do an arterial blood gas at baseline, and then you subject the baby for 100% oxygen for like 20 to 30 minutes, and then repeat the blood gas and look for the change in the partial pressure of the oxygen. The PaO2, if it increases more than 200, then it's unlikely to be cyanotic heart disease. If it is less than 100, then it is likely. Between that, it is possible. But this test should not be done in the presence of pulse oximetry screening for critical congenital heart disease, which is recommended by the World Health Organization for all newborn babies, because cyanosis sometimes is difficult to recognize, and it should be done for all newborn babies by checking the pulse oximetry in upper limb and lower limb before discharge. And then when do we say that the baby failed the test? If oxygen saturation is less than 95% in any limb, if any limb scored less than 95%, or the difference between upper limb and lower limb is more than 3 digits. For example, the upper limb is 99 and the lower limb is 95. So all are 95 and above, but the difference is more than 3 digits. The difference is like 4 digits. So this is failed. If it failed, then we repeat 3 times. If persistently failed, then the baby should not go home without having an echocardiogram. So this differential oxygen saturation can help in the detection of critical congenital conditions that sometimes can be life-threatening. The ominous signs for these patients, if you find a baby with central cyanosis and murmur, and the baby failed the hyperoxia test, or nowadays failed the critical congenital heart disease screening test with weak or absent femoral pulses, then you should consider prostaglandin without waiting for the confirmation of the diagnosis. And then these babies, usually they have decreased pulmonary blood flow, the cyanotic babies, and most commonly you will find an obstruction to the outlet of the right ventricle, like pulmonary atresia or tricuspid atresia, or sometimes unusual conditions like transposition of great arteries or other complex lesions. These patients, they all share the same problem of reduced flow to the lung, and this can be helped by opening the ductus arteriosus, and sometimes we do balloon atrial septostomy also to help that. The management should be the same like in the previous patient, except that this baby should not be subjected to high oxygen. Accepting lower oxygen saturation is very, very important, okay? So these patients, they can survive very well with low oxygen saturation, and we should secure the ductus arteriosus by prostaglandin infusion. Look for the side effect of prostaglandin always, which could be apnea or fever or diarrhea. If the baby develop apnea, then intubate and ventilate. Don't stop prostaglandin. Unfortunately, still there are people who are decreasing or stopping prostaglandin if the patient developed apnea. This prostaglandin is life-saving and it should continue. Accepting the low oxygen saturation is very important. These babies, they can survive with the lower oxygen saturation, but they cannot survive with closure of the ductus arteriosus. And the most important stimulus for closure of ductus arteriosus is the high oxygen saturation. And then they should be referred to cardiac centers for proper correction, like doing a BT shunt or other cardiac surgical interventions. In patients with transposition, the only difference is that sometimes they don't improve only with ductus arteriosus. Sometimes we need to do balloon atrial septostomy to improve the mixing of the oxygenated and non-oxygenated blood before taking these patients to for the definitive treatment, which is the arterial switch operation. Always remember the important issues when managing these babies. Regarding their nutrition, they have high demand, so they should get high calories as much as possible. Always correct their fluids and electrolyte balance. Avoid fluid restriction. Unfortunately, we are still seeing babies who are restricted in their fluid intake because they are cardiac. No fluid restriction for these patients. Actually, they may need higher. Avoid high FiO2, and they can receive some diuretics if you think that the lungs are congested, or you may use higher PEEP if there is evidence of lung congestion as well. Next case is a 2-year-old child who presented in another hospital, and this was the initial ECG that was taken. So this baby had failure to thrive. He was having difficulty to feed, difficulty to gain weight, and this is his baseline ECG. And if you look at the baseline ECG, you see the chest leads are showing clearly that the upstroke of the QRS has multiple levels, or what we call it delta wave. So there is no distance between the P wave and the QRS. The P wave is followed immediately by the QRS, very short PR interval, and then upstroke, which is abnormal. And this patient, during his stay, he developed this arrhythmia, which is supraventricular tachycardia. So these patients with arrhythmia, sometimes it is life-threatening as well if it takes long time, but also remember that it is well tolerated by small babies. So don't rush for strong medication or strong cardioversion. If you think that the patient is stable, admit the patient, try to manage by trying Valsalva maneuver first, by putting an ice on the face, or if it doesn't help, then IV adenosine. And then IV adenosine should always be given through a good IV access with a rapid bolus or followed by a rapid flush. If it doesn't work, then we may consider IV amiodarone, which usually helps. And then after that, the maintenance treatment by beta blockers. The next case I'm showing here is another patient that we have seen. This baby was full term, normal delivery. He was 3 kilograms. He was extremely well. And these are the vital signs. So for a neonatologist who look at these vital signs, if you follow the NRP, you should immediately start resuscitation of this baby because the heart rate is less than 100. But if you read the previous sentence, I said this baby is very well. He's vigorous, he's crying, he has good breathe, he's not in distress, he looks absolutely well, his blood pressure is normal. So if you see this, don't start resuscitation following the NRP. I'm not saying don't follow the NRP, don't start resuscitation for this particular baby, but try to obtain an ECG. And then if you look at the ECG here, you see that this baby has a slow heart rate, which is 76 per minute, but the P waves are much faster. The P waves, which are the smaller waves here in the lowest line, they are running at a rate of about 150, which is the normal sinus rate for this baby, while the ventricular rate is much slower. So this ventricular rate is the result of congenital complete heart block. These patients, they have dissociation, complete dissociation. You see one P wave has immediately next to it QRS, and then another P wave has very long distance until you reach the QRS. There is no relation between the QRS complexes and the P waves. So the cause of this is usually the antibodies that are transferred from the mother to the baby, and they may result in complication in utero. These babies sometimes in utero, they may have hydrops fetalis, endocardial fibroelastosis, pericardial effusion, or fetal demise, even fetal death. These patients, usually they are well and they don't need immediately treatment or immediate pacemaker. Actually, many of them, we discharge them home without pacemaker, without anything, if they are very well. Only we refer them for pacemaker if the baby has symptomatic bradycardia, or if there is marked activity intolerance for a baby, it is the feeding, or if there is evidence of heart failure related to the bradycardia, or there is ventricular dysfunction with this bradycardia, or there is wide QRS complex. If you noticed in the previous ECG, the QRS complex was very narrow, normal duration of QRS complex. If it is wide, then that's an indication for pacemaker. Or if we see BVCs or complex ventricular arrhythmia, or if the heart rate is very slow, like less than 50 beats per minute, if the heart is normal structure, or if it is less than 70 per minute in a baby with congenital heart defect. These are the American Heart Association guidelines for indication for a pacemaker of these patients. Other than this, these babies, they can be discharged home safely, and they can be followed in the clinic like every 2 to 4 weeks and monitored. And many of them, they continue for a few months without requiring a pacemaker. But when we follow them long term, almost all of them, by their teen age, they end up having a pacemaker. So delaying the pacemaker insertion is good because the risk of surgery is higher in a small newborn baby than in a 1-year-old or 2-year-old or 6 months old. And these patients, as I said, they tolerate this bradycardia well, but they should be monitored carefully. This is the end of my discussion. Thank you very much. And if there is any question, I'm happy to answer it.
Thank you so much, Dr. Fahd, for your excellent presentation. We'll just move direct to Dr. Mohammed Al-Ghamdi, and end of the session, we will see if there is something. If you are still with us, we'll call you, or if not, we'll send it to you.
Thank you very much. Thank you.
شكرا دكتور فهد، شكرا جزيلا. Our next speaker will be still pediatric cardiology, Dr. Mohammed Al-Ghamdi. Dr. Mohammed Al-Ghamdi is a pediatric cardiology consultant in National Guard Hospital and in King Khalid Hospital. Mohammed is one of the eminent pediatric cardiologists in Kingdom, and he will speak to us about BDA in premature babies. Okay, Dr. Mohammed, you have the floor. You can share your screen.
السلام عليكم. السلام عليكم ورحمة الله وبركاته. صوتي واضح؟
وعليكم السلام، واضح جدا يا بيه. توكل على الله.
طيب.
اعمل بس فول سكرين وسلايد شو وتوكل على الله.
يلا. سلايد واضح يا دكتور نبيل؟
Yes, everything is okay.
طيب. السلام عليكم ورحمة الله وبركاته. Good evening, everybody. I will talk today about the management of PDA in premature baby. And as a start point, you will hear a lot of conflicting messages or about PDA in premature baby. Do you need to treat or you don't need to treat? What is the best medication to give for such pathology. And I will try to explain it in a simple way and just add to it some of my personal opinion. As you know, the PDA is a very important part of a fetal life. This is the PDA here. Let me actually use the laser. Yeah. So this is the PDA here. It is very important in a fetal life because it diverts the blood from the lung, from the fetal lung that is not used, and shift the blood to the placenta, so the placenta can do the work of the lung. Without the PDA, the fetus will die. And there is certain medication that we try to advise mother at the end of pregnancy, like non-steroidal, not to take much because actually it can lead to premature closure of the PDA before delivery, and it actually can lead to significant fetal heart compromise and even death. After birth, the PDA are supposed to close, and there is actually many mechanism for that. We'll explain it in the next slide. But let's say the PDA did not close. If the PDA did not close, which is not needed after birth, that will shift the blood instead of going from pulmonary to the aorta, to go from the aorta, which is a high pressure, to the pulmonary now, which has dropping resistant. And that will lead to three important things. One, excessive flow to the lung, which lead to pulmonary congestion, stealing blood from systemic circulation, which will lead to, first of all, brain hypoxia, GIT hypoxia, and renal hypoxia, and hypoperfusion. And that will add too much blood on the left side of the heart. That might lead to the left ventricular dysfunction, which also will affect the systemic perfusion. So why there is a difference between term baby and premature baby in terms of their behavior and tendency of PDA closure? There is many reasons for that. First of all, the PDA close because of actually PDA remain open in hypoxemia, which happen in a fetal life, but more importantly because the placenta produce prostaglandin, which keep the PDA open. After birth, the hypoxia of the fetal circulation actually improve. So we have increased oxygen tension, and there is no placenta. Therefore, the prostaglandin production is much reduced in the baby after birth. But there is other mechanism that help with that. This example here in my left hand and your left hand is the PDA in a term baby, and the one on my right hand is the PDA in the premature baby. And if you see the difference, there is like much less smooth muscle in the premature baby on my right hand. Therefore, the physiological constriction will be less effective. Also, there is less vasa vasorum, which is actually this red point here, red circle, which help with the PDA closure. There is less endocard, sorry, they call it the intimal cushion, which help. Also, there is less platelet aggregation that help with the PDA closure. And also, there is less biochemical, what we call biochemical sensing mechanism. There is less receptor in the premature baby that will react with those, if you see here, the chemical factor that make the PDA in premature baby less chance to close. So therefore, in the premature baby, the PDA can remain open for a longer time. And it might be actually, in most of them, they will remain open. In 87% of them will remain open, especially if they are less 24 weeks and below. So we already talked about this. Persistent PDA lead to the shunt of the blood from the systemic circulation to the pulmonary circulation. Therefore, we will have pulmonary overshunting, systemic hypoperfusion, and left ventricular dilatation and dysfunction. So how is going to behave? And especially in those extreme low birth weight, I mean those who are less than 1,000 grams. There will be a pulmonary edema and pulmonary hemorrhage. There will be a hypoperfusion to the vital organs, which might lead to intraventricular hemorrhage, brain white matter injuries, necrotizing enterocolitis, and renal impairment. And whatever is written about the long-term in premature baby, especially those who are extreme, and they said there is no difference between treatment and no treatment in terms of the long-term brain development, a risk of intracranial pressure, and the risk of neck. To me, it does not make sense, because in those are extreme premature baby with a large PDA, what we call hemodynamically significant PDA, there must be an effect, and the effect either it is acute or long-term effect. That is clear, like physiology and pathophysiology mechanism, that I think there is a lot of conflicting data in the literature, mainly due to many confounding factors about defining what is significant PDA, what is not significant PDA, and having different term baby. Some are well and more than 1,000, and some are extreme premature. So I think myself reading about a lot of those article, and there's a lot of conflicting idea that is not making sense to me. Anyway, the diagnosis of PDA need high suspicion. And that will be if you start to see a decrease in a lung compliance in ventilated child, or the ventilatory support start to increase, patient require more oxygen. You cannot wean from mechanical ventilator. There is like hypotension, and you need to give inotropic support. There is decrease in the urine output. There is early sign of NIC, or there is persistent metabolic acidosis. If you start to see this thing and you have no other explanation, especially in those extreme premature baby, you have to put PDA or significant PDA at the top of your differential diagnosis, because it will lead to pulmonary congestion. It will lead to worsening ventilatory support for sure. We have seen it. It will lead to hypotension, white pulse pressure, active heart, loud systolic murmur, and as I said, metabolic acidosis and early sign of NIC. So the echo is the gold standard to diagnose PDA, confirm its presence, define it as significant or not hemodynamically. It also to assess the cardiac function, and very important to rule out cardiac structure anomalies that are duct dependent, that PDA should be managed in a different way. And from this, there is no clear guidelines about defining what is hemodynamic significant PDA and what is not. And I will tell you my opinion in the next slide. So it is not about the size of the PDA, because you might have PDA that is bigger size, but it is not hemodynamically significant. So if you look at the literature, they are talking about if the baby is less than 26 weeks, 1.5 and more is significant. If the baby is 30 weeks and above, 2 millimeter is significant. And I'm telling you from a long experience, measuring PDA, especially in premature baby with a poor window, sometimes is very difficult. So depending on size is not enough. This is the shunt pattern is very important. If you start to see PDA that has restrictive pattern, I will show you what I mean by that, or bidirectional, that is not significant PDA. Bidirectional, by the way, it can later on to change to significant, but those who has a restrictive pattern, usually it's not significant. Usually the PDA that's significant, what we call it pulsatile PDA, and I will show you the Doppler example of that. Also, if you have to assess the degree of pulmonary overflow, either by looking at the intracardiac anatomy, if there is any left atrial dilatation, left ventricular dilatation, and look in the ratio between the left atrium and the aorta. If the ratio more than 1.4, that's significant. However, if you have large ASD, the volume in the left atrium will distribute to the right side. So you might have significant PDA with normal LA size because you have a large ASD. So we cannot depend on only one number. Very important is the PA flow pattern. What I mean, the PDA flow pattern should be only during systole, and in diastole, you should not see flow by Doppler. If you start to see continuous flow in the pulmonary artery, that is a significant PDA. Again, the left ventricular size, it is dilated if there is no ASD. But if there is an ASD, the left ventricle will not dilate despite it is hemodynamically significant PDA. Then we are looking at the systemic hypoperfusion. If you assess the descending aorta flow, it should be only antegrade flow, meaning forward flow. But if you start to see diastolic reversal flow, I will show you example of that. That is significant PDA. If you assess, for example, the superior, the celiac artery or superior mesenteric artery, you should see antegrade flow during systole and diastole. If you see that diastolic antegrade flow, meaning forward flow, is reduced or become reversal, that is a significant PDA. This is what I mean by pulsatile PDA. This PDA, this is a PDA Doppler. You can see this is the systolic, and this is the diastolic. If you see significant difference between systole and diastole, that is a pulsatile PDA. This is usually indicates significant PDA. This is what I mean by continuous flow in the pulmonary artery. The red flow here is the PDA during diastole. And you should not see this blue in the PA branches. If you in a normal pulmonary artery Doppler, presence of the blue in diastole in the PA branches, and here the right pulmonary artery, that is usually indicate too much flow to the lung during systole and diastole, and this is very suggestive of hemodynamic significant PDA. This is the Doppler of right pulmonary artery. You should see like only one wave, but you should not see continuous flow. That is continuous flow. That means there is diastolic flow significant in the pulmonary artery that is indicative of significant PDA. Even this is so important, it is not written in all the criteria of significant PDA in the literature. This is an example of dilated left atrium and left ventricle in a patient with a PDA. But again, if there is an ASD, the left side will not dilate. The blood will distribute between the left side and right side. So you will not see significant dilatation of left heart chamber, despite it is hemodynamically significant PDA. This is abdominal aorta. You should only see red color, and you should not see blue. Blue, that's a diastolic reversal or reversal flow during diastole. This is indicate stealing blood from the abdominal organ to the pulmonary, which indicates significant PDA. This is what I mean by restrictive pattern. When you see the PDA, it's just like this. You see like systole and diastole flow. The one down, like it is not bidirectional. This is just abdominal aorta because this is continuous Doppler. Look at the one above the line. This is the PDA flow. The one below the line is the aorta. The one above the line, this is what we call the restrictive pattern. That means PDA is closing, and this is usually suggestive of non-significant PDA. This is true for premature baby. However, in older children, PDA can be significant with such flow pattern because of the chronicity. This is what we call it bidirectional flow. The PDA go here, up, then there is like in at the baseline, there is actually here double envelope. The big envelope is the PDA here. So the PDA going during diastole like upward or left to right. During systole is going downward, that's right to left. This PDA, even it is large, but still hemodynamic is not significant. Either the lung has significant RDS picture or pulmonary hemorrhage. This PDA should not be treated as significant PDA. However, if the lung condition improve, this can be, if it's still large, could be significant PDA later on. So how would you manage a PDA? So this is just a simple diagram. Show you how you look at it. You have to screen the PDA, in my opinion, around 2 to 3 days of life, regardless, especially in those extreme baby. Either you have clinical sign or no clinical sign. For sure, if you have clinical sign of PDA. If you find PDA is significant clinically and by echo, then you start treatment. And then it depends what you're going to use. Paracetamol, ibuprofen, or indomethacin. And again, there is conflicting idea, and I will refer you to a good article that describe all of that. But in my opinion, acetaminophen is very, like it is less effective in those extreme premature baby. And the PDA closure rate with acetaminophen or paracetamol is less than ibuprofen. Despite the what they call the PDA trial that showed no significance between acetaminophen and ibuprofen, and between ibuprofen and indomethacin in terms of the PDA closure. But actually, there is like a small paragraph there said that in extreme premature baby, the rate of closure with acetaminophen is much less than ibuprofen. And there is a randomized study after that, that the rate of closure in extreme premature baby with acetaminophen is about 6%, while about more than 50 with ibuprofen. And the need of surgical intervention in extreme premature baby is about 60 or range 60% in acetaminophen, while it is only 15 with ibuprofen, which actually goes with my clinical experience that ibuprofen is more effective than paracetamol in PDA closure, especially those who are extreme premature. If medical treatment fail, then we would go for the surgical ligation. I'm not going to go and describe the medication dosing because actually it is part of your protocol and what you need to monitor. And again, for the surgical ligation, if you PDA remain significantly large and the patient you have and then you go for PDA closure usually after 14 or 21 days of life, typically from thoracotomy by a clip. You have to be aware that surgical PDA ligation is not free of complication, including vocal cord paralysis, diaphragm paralysis. But very importantly, after PDA closure, you might see a child suffering a lot in the first 24 hours. And this is what we call it post-PDA syndrome. There is a sudden reduction in preload, sudden increase in the afterload, and the patient actually might have deterioration of cardiac function that usually improved in 2 to 3 days after the surgical closure. This is one of the best article I have been encountered. It's called PDA arteriosus in premature baby. It has been published in Pediatrics in November 2020. It is a state-of-art review article. It describes so many idea about PDA, and especially in those premature baby. comparing medication, went through many of those article and randomized studies. And actually, I really like it. This is a slide of that in defining the low risk and high risk. I would leave it for now. I really encourage you to read it. And this is actually the protocol is more complex than our protocol about do you need to treat or not? Do you need to prophylaxis, target prophylaxis in certain patient, in certain infant, especially those who are less than 26 weeks? And what is the benefit of prophylaxis and no prophylaxis? And what is the difference between paracetamol, ibuprofen, indomethacin? And what is the benefit of surgical ligation versus no surgical ligation? It is a very nice article. I would encourage anyone dealing with the neonate to read it very thoroughly and learn from it. In conclusion, significant PDA has the deleterious effect in premature baby, especially due to pulmonary overshunting and systemic hypoperfusion. When clinically suspected, echo should be performed. There is no one echo parameter that is enough to judge PDA is significant or not significant. It is a collection of parameters which has to match with the clinical finding. Medical management, in my opinion, for any significant PDA should not be delayed if indicated, and surgical ligation will be indicated if medical management fail to close the PDA or the medical treatment failed to make it smaller. This is actually the most of the PDA in a simple way. This is our book that was published internationally through the Springer. It is actually يحتوي على everything about pediatric cardiology in a clinical practice. This is a chapter about management of PDA in premature baby. Dr. Ali Al-Mudir, Dr. Hakim, Dr. Saif Al-Saif, and I was involved that we wrote about the PDA, and most of my slides are in this chapter. And thank you so much.
Thank you so much, Dr. Muhammad, for your excellent presentation. I hope that will help us to much. I think you know that we have a lot of these people, and we are encountered with such cases many times daily. So hopefully we will benefit, inshallah, from your schedule, that we can revise this algorithm and we can update our protocol. Thank you so much for being with us, and wish you good luck, inshallah.
شكرا جزيلا دكتور جميل دكتور نبيل والجميع الحضور.
شكرا حبيبي. You can stop sharing. You have listened. Dr. Muhammad, there is one question, if you are still with us.
Sure.
Do you recommend to do echo routine for preterm babies?
Echo team, you mean neonatologist?
Routine, yes, not a routine echo for preterm babies.
In my opinion, I think especially those extreme premature baby, I would recommend to do echo in day 2, 3, and especially those who has early sign. We want to be proactive. We want to have a child. We don't want to have a child that has pulmonary hemorrhage or losing his life because we delay management. So for sure, any extreme premature baby, I would recommend to have echo done in day 2, 3 of life, and then decided individually about every patient if required treatment or not. And maybe Dr. Nabil have seen that in our unit. We diagnosed many baby with significant PDA. Even we ask you guys, do you see any clinical sign? We say like you guys said maybe borderline. Once we start treatment, the baby improved. So I am a very proactive person. I don't think PDA is a benign condition. I think it's a very malignant and premature baby, and I am always aggressive with treatment.
Thank you so much. As you know, we are doing this regularly in our unit, and we are treating many patients with indomethacin or paracetamol as per the recommendation, and we are rarely need to do ligation after this. But I have just a comment. I was sharing in one study in Germany for the use of ibuprofen or indomethacin versus paracetamol in the extreme preterm babies. And the result was that, as you said, that indomethacin and ibuprofen is superior, and also that the chance for the PDA closed by paracetamol to reopen is higher than after closure, even, and documenting this with echo that the PDA was closed. But after some time, reopening, especially if the baby has sepsis, have anything, it will reopen more frequently with paracetamol than with indomethacin.
And this is, Dr. Nabil, what we have been seeing. I work in 5 in ICU.
Yes.
In different hospital, they are busy. And this is what I have observed clinically. I'm not just biased with one in ICU experience, with different ICU, different protocol. I have seen more PDA that does not close in those units who use paracetamol more routine. I have seen better PDA closure in those who using ibuprofen, indomethacin. And your study that from Germany actually proved the point, and it's against the study that was done 5-10 years ago that said paracetamol is equally effective with less side effect. I don't think so. And there is actually a new randomized study that showed in the article that I advise you to read that let me actually give you the number because this is so important to mention it. I'm not going to take time.
Okay.
I'll just give you that number and then we will all be done.
So thank you so much for your extreme important experience. And inshallah, I hope that this will help and encourage the neonatologist to be proactive and to try to treat and close the PDA as early as they can, instead of leaving the baby to have hemorrhage or to suffer for just 2 doses or 3 doses of indomethacin.
Thank you so
Thank
much.
you so much, Dr. Muhammad. Thanks for being with us. So now we will move to our missed lecture from the first session. Now we will go with again with Dr. Tariq Al-Tukhais. Dr. Tariq is Associate Professor of Pediatric Surgery in King Khalid University Hospital. He will speak to us about inguinal hernia in premature babies, early versus late repair. Welcome, Dr. Tariq, and you can start your lecture.
طيب بسم الله الرحمن الرحيم. السلام عليكم. الصوت مسموع؟
مسموع كله تمام. توكل على الله.
طيب, in the beginning I would like to thank Dr. Nabil and the organizing committee for this nice 7th webinar with the successful previous versions. So because we are talking about neonates, I prefer to talk about something that's common for surgeons and for neonatologists as well. With the daily practice, we've seen inguinal hernia, which is a very common problem in premature babies. And the incidence, as we know, increases as the gestational age decreases. And it is estimated that around 40% in males born at 24 weeks gestation have inguinal hernia. The only treatment is surgery. There is no other alternative for surgery to avoid hernia incarceration, which is estimated to be up to 28% occurrence. So while we are talking about the ideal timing, because repair before discharge during the NICU admission, when the baby reach 1.8 kg or 2 kg, associated with considerable morbidity, medical morbidity. So what is the best timing to repair before we discharge patient home, or wait until the child is grown and does not need apnea monitoring. So this is the problem. If we do it early, we might encounter some morbidities, mainly respiratory, or if we delay until discharge, the patient might get incarceration while waiting. As we know, preterm infants with inguinal hernia usually have serious comorbidities like ARDS, bronchopulmonary dysplasia, retinopathy, or intraventricular hemorrhage. And undergoing repair with these comorbidities may worsen the problem. And this raises many concerns regarding the surgical complications, because usually the tissue in premature babies is friable and fragile, and sometimes surgical injuries happen and cannot be noticed on spot. And it will be noticed when the child grows, especially males, and they have infertility. If they have bilateral inguinal hernia, there may be injury to the vas deferens or to testicular vessels because of friability of tissues. In addition to anesthesia complication, possible prolongation of mechanical ventilation, and possible delayed discharge from NICU because of surgery. Sometimes the baby is completely ready to go home, but when they undergo surgery for hernia, they are delayed for 1 week or 2. On the other hand, if we delay the procedure until after discharge, although there is possible lower risk of this risk we mentioned before, but this might increase the risk of incarceration. And it is a major problem, especially if the patient has no fast access to the hospital. So what is the opinion of the literature? Actually, the optimal timing is controversial. The literature review has many contradicting evidence. And there is no practice guidelines recommendation all over the world until now. This is one of the best studies about the ideal timing, comparing the early versus late inguinal hernia repair on serious adverse events in preterm infants. It was a multicentric randomized clinical trial. It's a recent one. They defined early repair which was done before discharge. Just when the patient is ready to go home, they operate on. Compared to late repair, when the preterm babies reach at least 55 weeks gestation and apnea monitoring no longer needed, and it can be done as day case procedure. The primary outcome was to see the occurrence of any serious adverse events, and the secondary outcome is the hospital length stay. Whether in the early group, they added the days after surgery to the total number of days, or when they discharge home, they added the day case to the total NICU hospital stay. In this busy table, please look at the first row, when they compared early versus late in the apnea requiring intervention. In the early inguinal hernia repair, there was 17.6% of these babies required intervention for apnea, compared to only 6%. Other parameters are almost the same. So the early repair group, they have serious adverse events, usually related to anesthesia, mainly apnea, prolonged intubation, or bradycardia. On the other hand, the late repair group, although they have low probability of having at least one serious adverse event, and also they have less hospital stay during the 10-month observation period. When they calculated the NICU hospital stay plus 1-day admission for hernia repair, it is less than when they repaired the baby before discharge home. And the benefit of late repair was greatest in infants younger than 28 weeks gestation, and those with bronchopulmonary dysplasia. So this paper concluded that the late repair strategy resulted in fewer infants having at least one serious adverse event, and these findings support delaying inguinal hernia repair. So it's clearly stated in this paper, they advocated for discharge patient, then bring them back again and do the procedure. But as we mentioned, the literature is contradicting. There is another study about the optimal timing, and they concluded that the risk of incarceration when we are waiting for the hernia repair, when we discharge the patient home and waiting for the elective repair, associated with double incarceration rate if we do it early. And this increase the incarceration risk should be one of the factors considered when deciding on the optimal timing of inguinal hernia repair. So this paper advocate for early repair before discharge. This is another one talking about the complication when we wait for late hernia repair. We discharge home and waiting for the elective hernia repair. And they stated that the complications among infants awaiting for inguinal hernia repair may be substantially less common than previously reported. What they mean the incarceration risk is much less than what have been mentioned in the literature. And the occurrence of significant associated morbidity is quite rare. But we have a lot of question mark about this conclusion because we've seen many incarcerations while waiting. And actually, we conducted a study in King Saud University during Corona time and COVID time when all elective cases are abandoned. We followed up all inguinal hernia and we found significant increased risk of incarceration. Although this is not only premature babies, all babies waiting for hernia repair. This is another interesting study talking about cost only money, regardless of early or versus late repair about adverse effects or incarceration. They talk about how much they spend if they do it early or if they do it late. And they concluded that if they use only the cost as the decision-making, repair of premature inguinal hernia diagnosed as an outpatient should be delayed. And this is very clear because if you discharge patient home from the NICU and wait for 1 or 2 months and you do it as one-day surgery, it is much less than if you do it at NICU and the patient stay 2 or 3 days in the NICU. One of the last papers talking about the ideal timing from the NISCIP Society, and they stated that the early repair is associated with longer procedure time. And we know as surgeons, we know because the tissue is friable and it is very delicate procedure if you do it in 2 kg baby versus if you do it in 6 kg baby. And it is associated with a higher rate of adverse effects, infections, reintubation, and reoperation, and associated with a longer post-operative ventilation days. What about the official societies and official bodies? Let's talk about the European first. The European Pediatric Surgeons Association, they concluded that there is a significant variation in the practice of pediatric surgeons. Some they do it before discharge, some they do it later on with no evidence supporting each one. And due to the concern of high risk of incarceration, repair before discharge was the most prevalent practice. Lower risk of post-operative apnea was cited as the most common reason for delaying surgery. And they concluded that randomized studies are needed to answer this question, which wasn't answered yet. What about North America? The American Academy of Pediatrics, they stated that the risk of hernia incarceration drives a preference to pursue surgical repair. Data regarding optimal timing of repair was conflicting and inadequate. So, in my opinion, my conclusion is the ideal timing of hernia repair in premature babies is still controversial. But we have few things to consider when we take decision. If we have a good NICU team, NICU care, and experienced surgeon, and OR is well equipped, I think doing these babies before discharge is much better for the baby and for the family. But if we lack one of these, either the NICU care or the operative care or the surgical care is not adequate, we should delay the procedure. One more thing, If the baby has a fast access to the hospital, I can negotiate with the decision to do it late or not. But if the baby is discharged and is away from the hospital or in a peripheral area where the reach to the hospital, a tertiary hospital, where NICU and surgical care is available, I think we should repair them before discharge to avoid a serious incarceration. So the decision making should be individualized according to the settings. And thank you for your listening.
شكرا جزيلا دكتور طارق for your nice presentation. Actually, as you recommend, we are doing our hernia repair for all premature babies before discharge. So thank you so much. قول يلا معنا.
Thank you دكتور نبيل. وعليكم السلام. أهلا.
كنت في شوية أسئلة.
اتفضل.
يلا.
presentation أحطه؟
ايوه افتح مثال السكرين بس خلص.
لحظة دكتور علي معلش. بس لحظة نخلص مع دكتور طارق.
في سؤال ليه ولا خلاص؟
دكتور طارق، دكتورة سميرة بتسأل what if the ovary or the testes are included in the hernial sac? Could we repair immediately or what do you think?
Well, if clinically we cannot reduce them, I mean, during the NICU, we cannot reduce the ovary. Yeah, it must be repaired before discharge. This is incarceration by
Yes,
definition.
we just had a baby last week, and there was some debate from the company, and they wanted to do discharge, and we insisted that the ovary is inside, and it's like what you said, it is incarceration, and we have to repair before discharge. And finally they agreed, and it was repaired. So you recommended to repair if the testes or the ovary are inside the hernial sac.
Yes. So the discussion about repair, early repair or versus repair, if there is no incarceration at all, that comes and goes by itself.
Okay. Thank you so much. Shukran.
Thank you.
Can I stop sharing? So now we will shift to our next speaker. Our next speaker will be Dr. Ali Abdu Nasser. Dr. Ali is a consultant PICU in King Khalid University Hospital, and he is one of the eminent consultants in Riyadh and maybe in the Kingdom. Dr. Ali will speak to us about acute chest syndrome. Welcome, Dr. Ali, and you can start sharing your screen. Dr. Ali, can you hear me? Unmute your.
السلام عليكم ورحمة الله.
عليكم السلام.
Is it clear now sharing?
كلير يا باشا، الشير زي ما انت عايز، توكل على الله.
بسم الله الرحمن الرحيم. نكبرها شوي ولا شوي؟ ايه. طيب.
start سلايد شو بقى
Is it okay like this دكتور نبيل؟
لا اعمل سلايد شو، لان حضرتك مش الشاشة مش فاتحة كلها.
طيب 1 minute.
Slide show from the beginning and you start.
It's
Yes.
okay.
Yes.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام.
أسعد الله مساكم جميعا، وأقدم الشكر للأستاذ الدكتور نبيل لاستضافتنا في المؤتمر الناجح سنويا ما شاء الله. نبدأ في الموضوع. موضوعنا acute chest syndrome in sickle cell anemia, as Dr. Nabil mentioned already. We'll start by background, then pathophysiology and clinical pictures. Then we'll see what investigation and then treatment and summary for what we are going to talk. Sickle cell disease is very common problem, talking about in the kingdom, especially in the certain area in the south and in the S-thrombophans. And I think the first case was discovered was in 1960s. And simply this is a disease which is single mutation at the beta chain of the hemoglobin, where is the substitution of the glutamate for valine, and this will lead to having abnormal hemoglobin and what we call it hemoglobin S. This hemoglobin S is different from the hemoglobins, the adult or fetal or other hemoglobin, but it's not fat soluble, and it simply lead to polymerization, and this is what called the sickling at the end and the occlusion of the small vessels. Regarding the regional distribution of sickle cell dam, as we said, it's mainly in both areas, south and the eastern province. Acute chest syndrome is defined as simply as acute illness characterized by chest pain, fever, acute new infiltration in the X-ray. It's always associated with the hypoxia, but hypoxia is not within the definition of the syndrome, and it might be used as indicating the severity. This definition include those cases with or without infection. And it is, and it can be as simple as simple pneumonia, and it might be as severe as severe chest syndrome, and it might result in mortality, not only morbidity. Historically, hemoglobin acute chest syndrome is one of the most common cause of death, because it leads to the respiratory failure and it causes death. And acute chest syndrome can also be associated with significant morbidity, including long-term parenchymal damage, in addition to pulmonary vasculature abnormality and neurological sequelae. What are the pathogenesis of this entity? Usually, it can be from simple disease, simple pneumonic infiltrate, to severe form of acute syndrome, which leads to multi-organ failure. The pathogenesis include 3 or 4 mechanisms, mainly pulmonary infection or fat embolism and pulmonary infarction. All of these 3 causes lead to the acute chest syndrome. The causes involve in the alveolar oxygenation for any reasons, either due to hypoventilation or due to the sickling, due to the hemoglobin S polymerization, or due to the hypoventilation, or due to infection, all lead to decrease the oxygenation, and this lead to the more sickling and more severity of the acute syndrome. There is evidence that VCMA, which is the vascular cell adherence protein, it usually increases in case of acute chest syndrome. This lead to more adhesion of the cells, more adhesion of the cell to the endothelium, to the pulmonary endothelium, lead to occlusion of these vessels and more hypoxia. This is simple and a diagram showing the mechanism how it happened. We can take usually started by regional hypoxia, lead to erythrocyte change in the shape. This lead to occlusion of some vessels, especially in the bones, lead to fat emboli, and this also affected the lung after it goes to the circulation, in addition to secretion of phosphodiesterase A2. This lead to shunt, in the presence of hypoventilation secondary to atelectasis. It happened because the emboli which affecting the ribs lead to severe pain. In those areas the patient cannot breathe, and lead to regional hypoventilation and atelectasis. All of this lead to shunt. This shunt lead to decrease the hemoglobin and decrease the oxygen delivery and also regional hypoxia, and this cycle continue. There is evidence the vascular cell adhering membrane, which also upgraded by the hypoxia and fat emboli, has a role in the development of the acute chest syndrome. An inducer of the red cell adhesion is
contributed to increase the adherence of the red cells and respiratory endothelium in the system, increase the vaso-occlusion within the pulmonary circulation, leading to more hypoxia. The most bacterial, if you are talking about infection, the most common bacterial organism identified in the studies done in the adult chlamydia. Like in children, we are talking about mycoplasma, we are talking about staph, we are talking, but commonly the most common cause of this infection is the viruses. Among of these viruses are respiratory syncytial virus. Mycoplasma has isolated in 12% of the cases and under 5 years of age, and 14 episodes in children between 5 to 9 years. But only 3% for those older children. Yeah, we know that the mycoplasma is common in the toddler, in the scholar. Staphylococcus aureus, streptococcal pneumonia, Haemophilus influenza, and others are also a common cause of infection. The clinician must carefully consider the antimicrobial agent when you have a patient came with the sickle cell anemia admitted simply with vaso-occlusive crisis, and there is some chest finding. Please consider both conditions. We are talking about the pneumonia and possibility of chest syndrome. Don't treat syndrome without antibiotic, and don't treat that pneumonia only without the measure taken usually for chest syndrome. We should teach to the junior, they should take both entity together and to be aggressive with the antibiotic therapy. Where the fat embolism as a second cause of the chest syndrome, where it came from? Usually we said with the repeated infarction in the bone lead to necrosis, and this will be released to the circulation and it will reach to the pulmonary vasculature and cause the hypoxia. Again, macrovascular pulmonary infarction, this is another cause of chest syndrome, and this is usually all the causes of the abnormal X-ray findings, which we can see in the coming slide. The macrovascular pulmonary infarction due to the same reason. We have either infection, we have or regional hypoventilation because of the chest pain or because of the emboli. All of these to lead to the hypoxia and affect the hemoglobin inside this vessel and lead to more hypoxia. As we said, hypoventilation, atelectasis. The hypoventilation, we said secondary mainly either to do overuse of medication, talking about mainly narcotics, or talking about secondary to severe bone infarction and lead to severe pain, and it will affect the quality of the breathing. Asthma, if we have both asthmatic child with the sickle cell anemia, it's really a serious issues, and a lot of them, we can consider 50%, they can go to the acute chest syndrome. They usually have almost twice as compared to those having only sickle cell anemia without asthma. This is simply, we can talk about the causes of the acute chest syndrome. If you talk about atelectasis here in this slide, pain due to rib and vertebral infarction. Also, you have reduced respiratory drive. We have here true thromboembolism coming from any part from the body, either due to vaso-occlusive or due to the red cell flexibility or due to activated endothelium. Infection is here. We have to consider it. This is one of the common cause of the acute chest syndrome, talking about either chlamydia, mycoplasma, staph, strep, paravirus, and why you are mentioning all, you have to consider in your covering all the possibilities. Keeping also in mind the possibility of H1N1. This virus also is common and associated with the acute syndrome. The covering should be part of the course of the antimicrobial. This is almost explaining the infiltration which we see in the X-ray. We said either due to this infiltration, either due to infection or due to infarction or due to pulmonary macrovascular closure secondary to this sickling and polymerization of this hemoglobin S. What are the clinical presentation? Usually, يعني came with the يعني acute chest pain. They can come with the fever. They can come with cough, but half of these patients present initially with only painful vaso-occlusive crisis. And always we have to remind our junior, no, it is maybe the beginning of the acute chest syndrome. All patients admitted with a painful crisis should be, as we said, considered as acute chest syndrome. Acute chest syndrome can develop post-operatively, especially following abdominal surgery in patients not giving enough preoperative blood transfusion. You know, those cases admitted, but this is طبعا the job of the anesthesia. He should يعني evaluate his patient, and no surgery can be done, I think, if the hemoglobin is around 80 or 70. Usually they are checking, they are giving blood transfusion, simple transfusion. Sometimes they go to small exchange transfusion if the surgery is badly needed, and they need to drop the hemoglobin down to between 20 to 30. Regular monitoring of the vital signs and at least daily should be done. Examinations are also essential. As we said, the symptom usually cough, chest pain, shortness of breath. In younger children are more present with fever and cough. Regarding the sign, they can present with the fever, tachypnea, tachycardia, wheezing, and also chest pain, including dullness if it is really significant chest syndrome with a significant pneumonic infiltration. Sometimes they can present with the pleural effusion. Hypoxia, and as we said, it's not in the definition with the acute chest syndrome, but indicate the severity. If you have a patient starting down to 80, this means really this patient, ultimately, he will go to the respiratory failure. Okay. طبعا regarding the X-ray finding, don't think we have all the cases to have significant infiltration. We can have chest syndrome initially with the normal X-ray finding. Please, this is very important issue. We don't wait for the X-ray infiltration to talk about chest syndrome. There is some challenging in the diagnosis of acute chest syndrome. This challenge usually it is the difficulty of and the overlapping between pneumonia and the acute chest syndrome. This is why I said in the beginning of the presentation, we have to attack both of them aggressively, especially regarding the antibiotic and antiviral if it is available. Pulmonary embolism may present with chest, also there is a confusion regarding the pulmonary embolism versus the pulmonary infarction from the sickle. Pulmonary embolism, we know this, the blood coming from other areas like DVTs and other. Like in pulmonary infarction from the abnormal hemoglobin, it's totally different. It is local issue, and usually having normal coagulation and even normal CT finding. Other issue is the fluid overload. Some of us, because we consider the problem of sickling, they keep giving a lot of fluid. So, according to their belief, this might improve. Yes, it will do, but up to certain limit. If you give fluid overload, it might also contribute to pulmonary congestion and sometimes lead to pulmonary edema, and this also worsening the issue of acute chest syndrome. Opiate, as we said, over treatment lead to hypoventilation, and hypoventilation lead to hypoxia, and hypoxia also lead to the hemoglobin polymerization, hemoglobin S polymerization, and also sickling and closure of the fizzles and so on, and this cycle continue. Alveolar hypoventilation, we said due to pain, and it's mainly due to the rib cage, to the ribs, and also the sternum. If the infarction there, the patient usually try to avoid ventilation and lead to regional small atelectasis in this area. What is the outcome of this? The severity of acute syndrome is variable, ranging from simple disease, it might end to also mortality. The older the patient with the chest syndrome, usually they do suffer more and the mortality is more. But overall mortality in these cases reach to between 3 to 5%. Hospital stay usually is shorter in children compared to the adult. Recurrence also is a feature of some patients, especially those who having always higher hemoglobin S. And we saw these cases usually in people coming from the south area, from the south, not from the eastern province. We know the difference because the cases from eastern province, they do have higher level of hemoglobin F, and this is why they are less prone to frequent vaso-occlusive crisis. طبعا other morbidity which can occur with this chest syndrome, you know, neurological abnormality, it can present with the change mental status, with seizure. Neurological symptom if severe, it will lead to respiratory failure. And there is a recent history that acute chest syndrome is a risk factor for overt stroke. A greater fall in the hemoglobin also documented for cases of bilateral lung involvement than for the unilateral disease. Respiratory failure is the common cause of death in this condition. Other causes of death include pulmonary hemorrhage and core pulmonal and overwhelming sepsis in addition to cerebrovascular event. Even those with the good medical treatment, the overall mortality, as we said, up to 3%. What are the investigations we used to do? Usually we have monitor oxygen saturation, we have to monitor the heart rate, and this is the blood work which we usually ask for, full blood count, basic biochemistry, blood grouping for simple or zinc transfusion, and we have to do the blood culture to isolate the organism for the choosing the proper antibiotic, and we have to do serology for the many virus, especially talking about PCR or RSV screen. Chest X-ray, as we mentioned, initially could be normal, but it could be bad as overall total white out chest, and also indicate the severity. This is some example of the X-ray. Remember, X-ray initially could be normal. Full blood count is very important, CBC, to check the hemoglobin. The hemoglobin, if it is dropped between 2-3, below the baseline, it will be worsening the acute chest syndrome. If we have a platelet coming down, reaching around 200, usually they do have higher platelet. This indicates the severity of the disease, and also it is an isolated risk factor for the neurological also involvement. Biochemical test, we said simple investigation, urea creatinine, also indicated to monitor the possible involvement of other organ, as the case might lead to multi-organ failure. CRB also is a useful marker for worsening the condition. Group screening, also matching. Infectious disease testing, it's mainly by either by screening by the blood culture, taking the mycoplasma titer, PCR for immunofluorescence for certain viruses. CT scan and VQ mismatching study or scan, this is also indicated, but usually we do it for severe cases. It's rather than, especially those cases coming frequently with the vaso-occlusive crisis, we have to save some investigation for the really severe one. Otherwise, we'll expose your patient to many times to the CT scan. Bronchoalveolar lavage for those causes who go to the respiratory failure and get intubated. Yes, this test might help us to recognize the triggering organism. What are the general aspects of management? Usually, it's mainly after investigation, and we go to the management just because of time. Mainly, it's painkiller. We have to consider the antimicrobial agent. We said we have to have at least double covering. If we are talking about, we have to cover the atypical infection, talking about chlamydia, mycoplasma. This macrolide should be considered part of the antibiotic treatment, in addition to other choices of like some third generation cephalosporin like Trixol. Antivirus, yes, if it is especially we are talking about H1N1, we need to cover these cases empirically. Other form of treatment, that's blood transfusion, simple transfusion. If the hemoglobin around between 8 to 10, we don't need to go more than simple transfusion. It can be given 3-4 times to ensure the hemoglobin at least around 10 to 12. But in severe cases where is already we reach to intubation, exchange transfusion need to be done, and that can be either manual or done in the by specific machine. Okay. طبعا advanced respiratory support we started by either simple high flow nasal cannula. Not working, we can go to non-invasive. Not working, this means we will end by, unfortunately, to small invasive intervention, which is intubation and ventilation. Okay. Other measure to be giving, we are talking about the bronchodilator, yani especially those cases with acute syndrome diagnosed with cases of bronchial asthma. It is the must and it's part of the treatment, bronchodilators. We have to talk about also the possibility of choosing steroid before inhaled nitric oxide. We are talking about steroid. Yes, some cases, severe cases, especially the case diagnosed in sickle in the presence of asthma, we can use steroid. Inhaled nitric oxide, yes, some people use it in severe cases. Corticosteroid, I already talked about it. Chronic complication, what might the complication of the disease may lead to scarring, pulmonary fibrosis, and chronic sickle disease. Prevention of the infection with antibiotics prophylaxis, it is helpful. Administration of annual influenza vaccine is also very important for such cases. Also, pneumococcal vaccine, it is a must for all children, especially cases of sickle cell anemia, to prevent the possibility of having this acute chest syndrome. Hydroxycarbamide, or what's called hydroxyurea, it is it is one of the medication, everybody know this is a chemotherapy agent. It is used to treat, and we are using it not only for chest syndrome, we are using it for older children, especially talking about after 5 years, to reduce the frequency of vaso-occlusive crisis, and it is really effective. And the mechanism of this medication, why hydroxyurea lead to decrease the vaso-occlusive crisis, or it is used as a prophylaxis to decrease the frequency or the incidence of Fuchs syndrome. Usually this medication found by chance to increase the hemoglobin F. The hemoglobin F is much, much better than hemoglobin S regarding the polymerization and the oxygen affinity. Else we can do. So in conclusion, this acute syndrome is a common complication of sickle cell disease, necessitating a frequent hospitalization and hospital admission. Physician caring for patient with the sickle cell disease should know for the clinical feature of acute syndrome, so that the optimal prevention management strategies can be started earlier. Families of affected patients should be educated about the scenarios of the complication and the need to seek immediate medical attention. They should know it is not a simple disease, it's not a simple pneumonia, it's not simple vaso-occlusive crisis. It might give a mortality, and we mentioned the mortality can reach to 5%. Early and aggressive supportive care and transfusion therapy has been associated with the marked reduction in the acute chest syndrome and also with its morbidity. Thank you very much.
Thank you so much, Dr. Ali.
الصوت وين الصوت؟
دكتور علي،
شوي دكتور.
سامعني؟
ايوه سامعك دكتور، تفضل.
طيب شكرا جزيلا. Thank you for your presentation. And now we will just stop sharing and we'll move to our last lecture.
طيب وين stop sharing?
Now we will move to our last speaker today, Dr. Safwat. Dr. Safwat, professor of in Egypt, and he is one of the stars in our private sector here in Riyadh. Dr. Safwat will give us a lecture about idiopathic increased intracranial hypertension in pediatric patients. Welcome, Dr. Safwat, and you can start. Just wait. أشيل خلاص. إيه؟ اقفل من فوق. بس.
السلام عليكم ورحمة الله وبركاته. مساء الخير. أنا عارف this is the end of the day. But first of all, I want to thank Dr. Nabil for his invitation to participate my work in this research. I want to thank Dr. Nabil for his invitation to participate my work in this respectable meeting with my colleagues and friends from the pediatric departments. My talk today maybe it is unusual in your practice, but actually we find that it is an important issue that want to alert and highlight this topic in pediatric practice. Our talk today will be about the idiopathic intracranial hypertension in pediatric patients. Idiopathic intracranial hypertension, it was known that is a rare disease in pediatric age group, but the incidence seemed to be increasing among children in the last decade. Pediatric idiopathic intracranial hypertension has been refined and mentioned by Professor Lessel in 1992. Due to the risk of visual loss and difficult diagnosis in the pediatric patient, this necessitated collaborative approach in the management of idiopathic intracranial hypertension in pediatric patients. The team should include the pediatric doctors, neurology doctors, ophthalmology doctors, and neurosurgery doctors. This is why we try to high alert and highlight this topic. In adult, the idiopathic intracranial hypertension is a condition of increased intracranial pressure without any laboratory or radiological evidence of intracranial lesion. From the beginning of the diagnosis of this disease, it was named pseudotumor cerebri because it has the same manifestation of brain tumor, but there is no brain tumor. After that, so they changed the name from pseudotumor cerebri to benign intracranial hypertension. But with the follow-up, they found that this patient can lose their vision. Loss vision couldn't be a benign condition. So the pathology was not known. So there is agreement that it's known now as the idiopathic intracranial hypertension. The incidence of idiopathic intracranial hypertension in adult patient is around 0.9 per 100 population. It's usually affecting more in the female obese patient in the childbearing period. And it was known as in rare in pediatric age group. The pathogenesis is until now it is unknown. The precise mechanism of the increased ICP is still unknown, but increased the venous sinus pressure and decreased the cerebrospinal fluid absorption were documented. There is some predisposing factor for development of idiopathic intracranial hypertension, however, in adult or pediatric patient. In spite, there is no known genetic abnormality, but familial cases have been reported. Some medication may lead to development of this condition, such as vitamin A, tetracycline, and the human growth hormone. Post-viral infection may lead to increased intracranial pressure. Hypoparathyroidism and the corticosteroid withdrawal also has been accounted. Vitamin A and vitamin D deficiency was found in some patients. Head trauma, iron deficiency anemia, and some metabolic disorder as a galactosemia was also found in some of these patients. Symptom and the sign of increase of idiopathic intracranial hypertension in adult divided into cranial finding and visual finding. Cranial finding includes the headache, nausea and vomiting, tinnitus, and diplopia or 6 nerve pulse. While visual finding, which are more common presentation, are the pupil edema, transient visual obscuration, blurring of vision, diplopia, visual field defect, diminution visual acuity. The treatment of idiopathic intracranial hypertension may be medical management in the form of acetazolamide, which decreases the secretion of these cells, Second point, repeated lumbar puncture. Third point, surgical management, which may be CSF diversion procedure as a lumbar peritoneal shunt or ventricular peritoneal shunt using stereotactic guided or lateral tunnel guided. Second, the surgical intervention or the optic nerve sheath fenestration. The most recent intervention is the dural venous sinus stenting, as some of patients were found that there is stenosis in the transverse sinus, and with the development of intervention radiology, they started to put a stent to dilate the venous sinus. The diagnostic criteria in adult are called modified Dandy criteria, which include the general sign and the symptom of generalized increased ICP, papilledema, which is the hallmark in the diagnosis, elevated cerebrospinal fluid pressure greater than 250 centimeter opening pressure, normal CSF composition, no radiological evidence of hydrocephalus, mass or vascular lesion. But what about the diagnosis in the pediatric patient? It should be include symptom, sign, and the ICP measurement. Symptom, headache, and visual symptom, papilledema, sign, papilledema, and fixed pulse, and the ICP measurement by lumbar puncture. But there is some debates regarding the value of the opening pressure in pediatric. Also, there is articulation of symptom in pediatric patient are very difficult. Also, in the examination, fundus examination in pediatric patient also is very difficult. So there is some challenges in the diagnosis of idiopathic intracranial hypertension pediatric patient, which includes the age cut point. In which age we can consider this patient is a pediatric patient or adult patient, as it's different from country to country and from area to area. Urban, suburban area has different parameter for the adult and the criteria. Presentation. Children are usually not able to articulate their symptom effectively. Third point, papilledema. Fundus examination in pediatric group is very difficult. Fourth point is the ICP measurement. Fallacies in the value of opening pressure during lumbar puncture in pediatric patient is very high due to crying, due to position. So we couldn't also judge on this. The radiological finding in pediatric patient, usually the imaging is unremarkable, so we couldn't depend on the radiological finding. But the risk of visual loss necessitates the collaborative approach in the management, as I mentioned before. To answer this question, we succeeded in our university with the pediatric department and the gastroenterology department to confirm and diagnose 17 patients less than 16 years old confirmed with idiopathic intracranial hypertension. And we divided them into two groups according to the secondary sexual criteria. And we published this article for anyone to read more details. We can reach it on the Egyptian Journal of Neurosurgery. We find that in the idiopathic intracranial hypertension is mainly in female obese patients. We couldn't find this in group 1, which are pediatric patients with confirmed idiopathic intracranial hypertension without any secondary sexual criteria. Obesity also not found in this group. Anemia was found in 71% of this patient. Urinary tract infection was found in 57%. ICP opening pressure was 134. Presentations, the most common presentation was the squint, which was a 6 nerve palsy, headache, blurring of vision, and visual obscuration. Recurrence rate was 28%. To answer the question, number 1, the age cut point. Age-specific criteria to define the puberty are unreliable. So we will depend on secondary sexual criteria to define the pediatric intracranial idiopathic hypertension. As patient with secondary sexual criteria, they should be considered as an adult patient, while pediatric patient with this symptom without this criteria should be considered as a pediatric patient. Symptom and the sign. Headache. In adult, headache it was found in more than 80% of the patient. While in pediatric patient, they are not articulate, and there is multiple causes of headache. So we couldn't depend on this symptom. Visual symptom, blurring of vision, diplopia, and squint. To the presentation, our patient with some of the diagnosed cases were asymptomatic with accidental discovery of papilledema during routine eye examination. Squint, which is the 6 nerve palsy, and the headache can be expected in pediatric patient with deterioration of the school performance, interrupted sleep, personality changes in the personal habits during studying or during watching TV. Second point is the papilledema. Papilledema is the hallmark of the diagnosis of idiopathic intracardiac hypertension, ranging from mild bleeding of the disc margin to gross disc swelling with hemorrhage. But fundus examination of that group is challenging due to sometimes pseudopapilledema. So we recommend to refer the patient to ophthalmology consultant and do the examination under sedation using the indirect ophthalmoscope, which is more accurate, and do fundus photography for documentation. ICP measurement or lumbar puncture technique in pediatric patient is challenging. What is the diagnostic level? Because what is the diagnostic level of ICP pressure? And is the idiopathic intracardiac peripheral in pre-order children considered pediatric or not? A lot of researchers do this in this and find that the opening pressure is more than the normal patient. It is more than 18 centimeter. Opening pressure in children under 8 years should be considered diagnostic for idiopathic intracardiac hypertension, while in more in patient in adult patient more than 25 opening centimeter water. Transient elevation may occur with physiological events as crying, including sneezing, coughing, and valsalva maneuver. ICP is slightly higher with deep sedation. ICP can be affected by body mass index, as obesity may increase the ICP, so this should be considered. According to this is the study that studies the opening pressure in pediatric patient. Radiological finding, usually radiological finding is normal, هو the CT scan or the MRI. But in our study, we consistent to do the CT scan, MRV and MRI. And we found that in two weighted images revealed flattening of the spherosclera, vertical tortuosity and elongation of the orbital optic nerve, distension of the perioptic subarachnoid space, and partially empty cella. This in patient, we found this finding, we should consider it as idiopathic intracardiac and go further for further investigation. So we can conclude the diagnosis of idiopathic intracardiac hypertension in pediatric patient into symptom and sign, which is the headache, decreased school performance, abnormal sleep, weight loss, loss of appetite, 6 nerve palsy. Radiological findings are the venous sinus stenosis, flattening of the posterior sclera, tortuosity of the optic nerve, and partially empty cell syndrome. And opening pressure in calm patient should be above 100 centimeter water. Recurrence rate. In adults, the recurrence rate is almost 40%. In pediatric population, the recurrence rate is low, between 6 and 25%. But in our study, we found that the recurrence rate in pediatric patient is 28%. Recurrence is most likely to occur during the first 18 months after diagnosis. In conclusion, pediatric idiopathic intracardiac hypertension is not uncommon, and it should be considered in any headache syndrome in pediatric patient. Idiopathic intracardiac hypertension may have catastrophic complication, should be taken seriously. Lumbar puncture is indicated for both diagnostic and therapeutic purpose, as it considered the best line of management. Patient less than 16 years old with secondary sexual criteria has the same diagnostic criteria for adult idiopathic intracardiac hypertension. Recurrence of symptom is relatively high. And so my recommendation, and I ask you to take your home message, that children with idiopathic intracardiac hypertension at risk for visual loss, and their visual function must be closely monitored. Ocular health regular monitoring, even in healthy children, should be followed. Confirm papilledema, whatever by sedation or by using an endoscope or using the fundus photography. Correct lumbar puncture technique should be considered. MRI brain, orbit, and MRV should be the full imaging protocol, including again MRI brain, orbit, and venogram. Surgical intervention is can be needed in some cases, especially if the vision is threatened, and you should transfer the patient to the neurosurgery doctor. So pediatric idiopathic is a rare condition, is not a rare condition, and we should consider it a serious complication as it affects the vision. Idiopathic intracardiac should be considered in pediatric patient for any headache syndrome. In adolescent children, clinical picture is similar to that of adult idiopathic intracardiac hypertension, but in younger age group, there is no gender difference and usually non-obese patient. For this, at this point, I want to thank you for your attention, and I am ready for any question. Thank you.
Thank you so much, Dr. Safwat, for your excellent presentation. With this, I think if anyone has any question, we can still have. If not, we are coming now to conclude our first day for the symposium. I want to thank all the speakers for their time, for their experience and knowledge they shared with us. I will check if this is you recommend an eye examination. You recommend an eye examination every year. طيب يلا you can answer.
Actually, we make every 6 months examination, especially if there is any family history or is there is any deterioration of the school performance or loss of identified.
دكتور الصوت مش واضح، أستأذنك الصوت مش واضح.
واضح كده يا جماعة ولا إيه؟
دكتور نبيل الصوت مش طالع.
اقفل وافتح تاني. اقفل وافتح تاني. كلير ناو؟
تمام دكتور تفضل. تمام دكتور تفضل.
For routine eye examination for pediatric, we recommend routine examination every 1 year if there is no symptom. But if any symptom or any change on the kids' habits during the school or at home, we should consider examination every 6 months.
دكتور نبيل عفوا صوتك مش طالع.
والله أنا تعبت كده الصوت طالع وعمال
كده
يطلع.
تمام كده تمام كده تمام.
أعتقد إن هو إنترنت بروبلم. Tomorrow we'll connect with the direct cable أحسن. So with this we conclude our day for today. Thank you so much for all the speakers, all attendees, and we'll resume inshallah tomorrow at 4 p.m. Riyadh time. Thank you so much. Wishing to see you tomorrow inshallah. شكرا.